Good afternoon, everyone, and welcome to day three of our college internship. I hope the last 2 days have been a good learning experience for all of you. As we speak, I am adding the attendance link for today, and it's also been added to the description of today's video for people who are trying to access the assignment link for the past 2 days. That has also been added to the description link for the respective days videos, and it will be live until 15th of July. So you can feel free to take your time, learn, brainstorm, and then attempt the assignment. All right. So today is a very interesting topic, a very important, relevant topic in the field of clinical psychology. So it's about clinical interviewing skills, where we'll be covering this in two bits, where we'll be talking about case history, and that will be taken by expert, Dr. Mantosh. I'm adding him right now. Welcome, Dr. Mantosh. He's a psychiatrist with us, an expert in the field who will be guiding you through case history and mental status examination and its importance in the process of clinical interviewing. The second part will be about therapeutic alliance skills um, by our second expert of the day, Kamna Serene. She's a clinical psychologist with us. Again, an expert who's going to help us understand the actual skills and the nitty gritties we need to keep in mind while we are building a therapeutic alliance within our clinical practice. So, welcome to both our speakers, and I'm going to hand over the stage to both of you, and I'm adding the presentation as well.
Thank you,
Okay.
Roshni.
Thank you, Roshni. I think I'll go first with the topic. Before we start, it's going to be a very big topic for all of you people. Try to be more attentive. I know anytime when more than 45 minutes goes, 40 minutes goes, people's attentions kind of, take a hit. But try to pay as much as possible, uh, pay as much as attention. We'll start with clinical case history taking, and then we'll talk about MSc, and Kamna will take therapeutic alliance. So let's start. Just to make you understand, it's always better to kind of listen to your patient. Active listening. A lot of times the diagnosis is sometimes straightforward. You can understand a lot when you are attentively listening to the patient. um, why are we even talking about case history taking and MSc? uh, that first interview, or the first time that the patient or the client sits with you, is the most important time when the patient will get enough uh, confidence to talk about themselves. If you are actively listening to them, you have to give them that environment of safety and where they can open up, and then you build a rapport on the whole, in this situation, and then from here onwards whole conversation starts. This MSc case history taking, it's has to be a lot more also at the same time interactive. The questions put forward by the interviewer should be in a sense that it is open-ended. It is going to very occasionally you have to put forward direct questions, but otherwise it's an open-ended question, and it has to be more interactive. um, we look for reliability of the information, and that is why sometimes we also ask the family members or friends or caregivers, whoever is possible, to kind of contribute into the case history taking. While you are talking to the patient or to the client, you are also observing their mannerisms, their behavior, their overall attire, and that also helps in making your case history more robust, more valid. We, at the same time, when we are talking to this person, we are also trying to understand the differentials. We are not just focusing on one aspect. If someone says yes, depression, then we are not continuously just thinking about depression, because depression, for example, can be a part of other mental health conditions. So you are also ruling out the differentials in your head, and then you come at a diagnosis which then helps us in reaching the management. And the management is not just about the medicines or just therapy, it's a holistic treatment, whether the patient alone requires therapy, patient alone requires medication, or if family members have to be included in the whole treatment aspect, any supportive treatment is required for them as well. So everything becomes a part of this whole case history taking. And you cannot go in for deeper dives every time that you meet the patient. So first, when you are taking the case history, make sure that you have ample time, ample opportunity to sit with this individual and talk to them. Now, components of history taking, which we'll talk in details: simple identifying data, chief complaints, HOPI, which is history of presenting illness. These are the criteria in which your history of presenting illness should be described as: onset, duration, progress, precipitating factors, history of past illnesses. Uh, then we talk about, sorry. Then we talk about family history, personal history. When we talk about personal history, these are the sub headings that we look into: birth and early development, early childhood. We'll talk in detail in the following slides. So identifying data and demographic data provides a demographic summary of that individual: age, sex, education background, address, everything, locality, culture, religion, any important data becomes an identifying data or a demographic data. You also mention here that the patient, whether they came on their own or they were brought by people from the family or caregivers, because that helps us in understanding, um, is there any insight to the in the individual that we are looking at. If the person came on their own, then definitely looking they are understanding that they're going through some problems in their lives, and that is why they want to kind of seek help from the professionals. So when they're, and on the contrary, if they're brought by relatives or any other caregiver, then probably the insight, the understanding that I have a problem is probably lacking. So that kind of helps us understand the situation. uh, so patient characteristic, anything which you think will help us understand the prognosis, well, which will help us understand how the treatment will be managed. All those potential factors need to be mentioned and kept into the data and the information. Now, the information that would be required: name, marital status, sex, age, education, occupation, place of residence, nationality. All these factors are relevant in understanding what the individual has the probability of going through. So when we talk about age, we understand that certain mental health conditions happen in certain age group of an individuals. Or when we talk about sex, then sex, how the individual's sex plays a role in certain diagnosis. Educational background helps us understanding how much of an understanding the patient can develop when we try to educate them. Nationality, citizenship, helps us understand there are certain disorders which are prevalent in certain parts of India or abroad, and migrant population suffer from different kinds of mental health issues. Certain parts of the world experiences some form of trauma, so that also kind of helps us understand the diagnosis where it is heading towards. So everything is important when we are looking into the identifying data. Now, chief complaints are, in simple terms, what the patient describes in their words: this is the reason why I have come here. Point one, point two, point three, point four, whatever number of complaints that they talk about. Always it has to be recorded verbatim, no matter how irrelevant or bizarre it might seem. Whatever the patient or the client is telling you, you kind of note it down the way it is. You don't try to change the wordings or to make sense of the wordings. If the patient says something completely irrelevant or completely bizarre, you note it down the way it is. Okay. It states those accompanying the patient can also give their own versions of the chief complaints, and that you can mention it separately. So what the patient or the client says and what the caregivers or the family members say, that you mention down separately. Few of the questions that you can, open-ended questions that you can ask, are simple, like what brings you here, and I generally utilize this: so how can I help you today? I mean, what brings you here? So these are the simple questions that gives an the person to kind of say whatever they feel like, whatever complaints. You can always say, is there anything else that you would want to add here? So again, you're giving an open-ended question. So whatever they want to add, you just write it down point-wise. When we go into the history of presenting illness, which is also called as HOPI in short, so in here you delve deeper into all of the individual complaints that the chief complaint kind of enumerated. If there are four chief complaints, going one by one with each of the complaints, you start talking in depth in understanding what exactly do they mean by it. You go in the chronological picture, in the sense that you talk about this onset of the problem. Let's say if someone talked about, I am experiencing difficulty sleeping, so you ask about when it start to happen, how long has it been happening, so some simple things. You talk about onset can be sudden, acute, insidious. Sudden happening within a few hours to sometimes days. Acute is within few days to weeks, and insidious is something which happens over a period of weeks to sometimes months and very slowly. Duration, how long the symptoms have been there for. Progression, whether it is stable and whether it is progressing and deteriorating, whether it is fluctuating, sometimes present, sometimes not there. Episodic, improving. All these factors will help us in understanding the diagnosis, and that is why it is important for us to note down. Let's say, for example, we are talking about delirium. For instance, delirium is a very fluctuating problem with problems with orientation, time, and time, place, and person, difficulties in that, but it is fluctuating. It does not remain constant throughout the day. So that gives us an understanding that probably we are looking at something which is a delirium condition, where person is going through delirium. So similarly, disorders which can be episodic to stable, or maybe the person is improving, whichever progression the person is going through. Immediately precipitating events or triggers. Most of the times when the patient comes to you with the complaints that they're experiencing, they will talk about certain precipitating events or the triggers that they're talking about. But let's say if a disorder is chronic in in condition, then maybe every time that episode happens, you might not get any triggers, and you there might not be any precipitating event, because sometimes the neurochemistry changes. Again, a helpful marker for us to understand where the diagnosis is going. Any factor which further exacerbates the condition or helps in relieving the condition, that should also be noted down. And most importantly, then, how is it impacting, how all the symptoms are impacting this individual in their functioning, whether it is personal, interpersonal, or occupational functioning. Symptoms then have to be summarized in a chronological progression, highlighting the symptoms. So whatever happened first, if someone had developed headache, fever, I'm talking about general medical, problems, headache, fever, loose motion. So what happened first? You mentioned that complaint as the first, problem, and how long did it last? What was the onset and duration? How sudden or acute or subacute? All those things you mentioned that way. So, and you also in the history taking highlight the significant events. Again, you can ask certain questions to help the patient come up with answers. How did this all begin? Any specific events that you remember around that time? What is the difference noticed in behavior? So these are the questions that you can keep putting in between. History of past illness, again, becomes a very relevant, important aspect. Let's say we are talking about bipolar disorder, and we are looking at that there is a history of previous episodes in the past, noting down all those things that happened in the past, how long the period lasted, what was the response to the treatment. So what exactly happened in that past history in the in the past, that also helps us understand how the disease will, or the disorder will, progress in future. So those information is also to be noted down. Okay. It includes both the psychiatric and the medical histories and the illnesses. We take into a factor that there are certain medical illnesses which can also aggravate or cause certain psychiatric illnesses, or they are comorbid along with psychiatric illnesses. So we take down into the account whether it is a psychiatric illness or a medical illness. Okay. uh, One important factor is that it serves as a transition between the history of present illness and the patient's personal history that we go back and which we inquire further. So past psychiatric history, any symptoms, contact with psychiatric services, details of treatment, response to the treatment, any previous hospitalizations. You talk about those things. Uh, so sometimes people don't go to psychiatrists; they sometimes go to general practitioners. So any symptoms that the general practitioner kind of help them get better with. So you can ask again certain questions: what treatments have you had, any similar other psychiatric problems in the past? So something, and all these questions are very open-ended questions. Past medical history, list past or present medical illnesses and treatment details. Various medical illness contribute to psychiatric symptoms, and it can go either way. Most of the times, let's say for example in schizophrenia, it's very common to see that people who have schizophrenia eventually do develop, whether they take the treatment or not, it is not related to that, but they develop either diabetes or hypertension, or they develop other chronic illnesses, hypertriglyceridemia. So various conditions are sometimes associated with psychiatric illnesses, or sometimes vice versa, medical illness can also lead to psychiatric illnesses. So you note down all those things. Okay, any information regarding neurological intervention, surgical, cardiac, should be specifically asked, because they help us identify the progression, the cause, the response to the treatment, everything kind of helps there. So here is one of the charts how you can make a demographic, and the family chart includes, you talk about the family members also. Family structure is depicted like this. uh, let's say we are talking about this diagram. If you can see, the circle represents a female, and the box, the square, represents a male member. The cross talks about if the person has diseased. If there is a single vertical lines, multiple vertical lines, that kind of tells us that this person had some psychiatric illness or is suffering from some psychiatric illnesses. So similarly, when a line joins between a box and a circle, that means these two are related through marriage. And when through marriages, when we drop down boxes or circles, that means that these are the offsprings of this particular couple that we are talking about. Um, any substance use is kind of shown by a horizontal line, a single horizontal line. Any when we shade the this thing, when we kind of sorry, yes, when we color the boxes, that means that the person is going through some kind of criminal justice system. Highlighting the borders of the circle or the box represents the victim who has probably been in any form of condition where they have faced a lot of trauma or any form of atrocities. So yeah, um, in conclusion, like we talk about brief statement about the family members, we are talking about any psychiatric illness and treatment that they have received. Family history is important because a lot of psychiatric illnesses have a huge amount of genetic overload, genetic history. Genetics play an important role in understanding uh, whether diagnosis is heading towards a certain way. uh, Also, what medicines the family members responded to, sometimes because they carry similar genes, then even that helps us in the choice of medication. Because the response, if the either of the parent or any other sibling were given to certain medicines, the sibling or the parent responded to that medication, then this person that we are talking about might also respond. So we take down in detail of all these informations. One important aspect which sometimes we forget to ask is, what was the reason or what was the cause of death of the deceased family member? That should be mentioned. Sometimes we don't ask and we skip, and we get to know about any medical history which led to the death of the individual, or maybe there was a psychiatric illness which eventually led to the death of an individual, whether the death was due to suicide or other relevant information. If we're not asked, then can be sometimes missed. So that again helps us in understanding the diagnosis and the management, how the management should be. So every information, no matter how small it might seem, is important. Here, role of patient's illness in the family has to be kind of discussed. How has your family responded to your illness? What does your family feel about your illness? That helps us in understanding again how the illness will progress with the treatment. How the family members understand the role of the diagnosis in the individual's life. So every information helps us manage the patient a little more better. Okay. And in certain aspects where these questions, when you feel that the family is not being able to understand, that is where the role of family intervention comes into play, because we need to inform the family, we need to educate the family sometimes more about the diagnosis, about the illness, about the disorder that the individual is experiencing, the signs and symptoms. Again, negative history is also important. This helps in understanding the differential that we are looking at. Rule out any history suggestive of mania, psychosis, depression, anxiety, substance use. Why specifically we have included these is sometimes we forget to ask certain questions around this. Let's say if you're looking at depression in an individual, and we forgot to ask about any history, past history of any symptoms suggestive of symptoms that points towards a diagnosis of mania, and we don't discuss further and start the treatment. And that individual, if the person has bipolar disorder because they had experienced mania before but they did not mention it and you forgot to ask, and we give the treatment for depression, the risk of you uh, you know pushing the person towards a manic episode is very high. So I'm just giving you an example. So this is how uh, not a detailed history, or when we did not inquire much, we just got the diagnosis, we understood that this is how it will help, and we proceeded further with the treatment without understanding that our medication can sometimes lead to a manic episode in that individual, and that should be, that is completely avoidable. Similarly, substance use, OCD, dementia, substance use is very important to understand how the person is going to respond to the medication, how substance interacts with medication, how we have to even start talking about the role of substance in the diagnosis. So this all negative history is important. Personal history, to just to understand the patient's holistically. You're not just looking at the person in the category of how, what is the diagnosis, what is the disorder doing to them. You understand everything about them so that you know how the treatment again will help this individual. So you talk about any birth history, early development, early childhood, education, occupational, marital and psychosexual, substance use, and any legal history. Now most of the times the people will come about and say that we don't remember anything about our early childhood. That is where it's better to involve any family member to also get the history around the pregnancy, and uh, how the early development was, whether the milestones were achieved normally or not. But sometimes even these two questions, the example of it, that can help us figure out. The first question is, do you know if there were any problems with your mother's pregnancy and your birth? Maybe if there was any problem, then people generally talk about it and one gets to remember those things. Second question is, as far as you know, did you walk and talk at the normal ages? This is again something which, if the individual was not able to achieve, the family would have kept mentioning it here and there. But if at all the patient is not able to kind of report, then getting an information from a reliable informant, whether a family or close family member or a parent itself or a sibling who was older enough to remember these things, those that kind of is important. Okay. If there were any problems, then inquire about prenatal, birth, perinatal complications, time in special care, and pediatric follow-up. Again, relevant from the point of view of treatment and how the prognosis would be. Early childhood history could be, inquire about the family environment, mother-child relationship, friendships, play, how how many friendships the individual had, how easy it was for this individual to mix up with people around them or children around them, separation from caregivers, methods of discipline, any significant illnesses, injury, trauma. Uh, Now, these are questions which help us understand the temperamental and behavioral problems in early childhood. And these are again very open-ended questions. Some of the examples are: what was it like growing up in your family? What were your parents and sibling needs like, and how did you get along with them? Again, very open-ended questions, nothing very directed. Let the patient kind of come up with the answers. You don't have to guide them into saying certain things. You just leave it where it be. If they're not able to answer, you can again move from one question to another, but let the patient give more and more information. Another question is, was early childhood a happy or a difficult time for you? Were you scolded or punished as a child? What were some of the reasons? Did you get into trouble very often at home or at school, and what would that be like? So open-ended questions. Education includes interest in school, academic progression, achievements, adjustment to school, relationship with teachers. Okay, let me. mm, yeah. How was your social life? Did you enjoy your time at school? Okay. Okay. How was your school life? Did you enjoy time at school? What did you like doing? I generally ask, what are generally your hobbies, and what do you like to do in your free time? So these questions are very open-ended and lets the patient also help in develop a rapport with you, so that they understand that person is not the professional is just not looking at the diagnosis, but they're also interested in knowing about the individual, the person as such. uh, Talking about the occupational history, list of jobs, and in a chronological way, the duration and the reason for leaving any jobs. Inquire about the quality of work relationships, any consistent problems faced with work-related conflicts. Why are we doing this? That we are looking for some kind of trend that the patient is exhibiting every time that they leave a job. Are they not able to perform well, or are they saying that everyone conspires against me everywhere I work? So that kinds of gives us an idea that even at a job it is creating some bit of dysfunction. um, again, open-ended questions. How are people at work? Do you like get along with them? Is your work stressful? Marital and psychosexual history include all significant relationships, just not don't stick to marriages. You can also talk about most important, yes, becomes marriage, but apart from marriages, any significant relationship that matter to that individual. So inquire about quality of relationships, specific areas of conflict, patterns of communication. This will help more in marital therapy, counseling eventually, or even in understanding the support system in the family. Also inquire about those sexual relationships and problems, any problems that they have faced. Substance use and misuse include all the past and present use of drugs, alcohol, and cigarettes. Include every particular substance individually, again in that chronological order. Which one started first? What are they doing currently? How long have been doing it? What is the frequency? What is the quantity? What is the duration? So any attempts at detoxification, or any attempts that they have remained abstinent from a particular substance, and what was the reason why they got back into it? So all these questions can help us understand the individual in a better way. Again, open-ended questions. Consume any substance? When have you been consuming? Has the intake changed over time? How were you introduced to it? Important to know that. Um any specific problems that the individual faced because of that particular substance, whether there was withdrawal fits in cases of alcohol, or in case of substances like cocaine or heroin. There are a lot of withdrawal symptoms that the person experiences. Have they experienced those withdrawals before, and what kind of withdrawals was that? Was it a uncomplicated or complicated withdrawal? So uh, again, going to help you in the forming the treatment plan or the management of the individual, whether the detox should happen inside a hospital setup, or it can be done at home in the outpatient basis. So that kind of gives us an understanding. uh, and talk about any misuse of prescription medicines as well. A lot of times, uh, a lot of patients talk about taking medicines as a substance. They abuse those substances to achieve certain high euphoria, or whatever problem or whatever issue that they want to kind of relieve themselves with. Um Legal and forensic history, any transgression with the law, criminal proceedings, charges against the patient. Uh, this information is helpful to understand whether it was a substance use or any other problem which led to such kind of criminal proceeding. How do they feel about it? How they are dealing with the stress of that? What all consequences they have faced because of that? So again, holistic kind of view of this individual that we're talking about. Um, Another question is important: is the psychiatric treatment court referred? So this individual, is it here? Is this person here because they want to be here, or they were asked by the court to be to get a kind of an assessment or a treatment done by a psychiatrist or psychologist? So those information become very important. Okay. List offenses, noting seriousness, convictions, and sentences. So how frequently this individual has probably uh, doing certain things which are wrongfully, which are legally not allowed. Some mistakes that they have done, some criminal offenses that they have convicted. um, this helps us understanding also the personality of the individual, again going to help in the treatment aspect. Also, were you under the treatment when lead to the problem in that individual's life. uh, Pre-morbid personality is to understand that individual before any of the chief complaints that they're talking about. Before that, how that person was, how the person had a life, how well adjusted they were, or did they have any difficulty while growing up. Also, that kind of helps us manage the individual in a better way. um, um Gives us an idea about how much the illness has impacted the person and expectations of treatment. So again, questions like, before all this happened, what kind of person were you? How would your friends describe you? Easier to understand. So now here we are kind of doing a sum total, like a paragraph. You can just write a summary of that whole history of present illness, past illness, family, psychiatric, psychiatric and medical past illnesses, negative history. So everything you kind of consolidate and you can make a summary. So sum total of examiner's observation, impressions of patients at the time of the interview, you note it down. Um, so we talk about uh, at the same time now mental status examination. So the first part was case history taking, and the second important aspect is mental status examination. Now interestingly, when we talk about MSc, it's not a separate part that you will tell the patient, now we are going to do MSc for you. It's never like that. While you're talking to the individual, while you're talking to this individual who has come to you, is sitting with you, you are doing your MSc while you are in conversation with them. And MSc is not something which, there are certain questions which will definitely be specifically as a part of MSc. But while you are talking about HOPI, while you're talking about past history, family history, you listen to them, you understand them, and you are also uh, kind of noting down what the MSc of this individual is. Now, where the case history remains stable, the chief complaints will remain the way that it is, the past history will remain the way that it is. What you do every time that you talk to the individual becomes an MSc. And then you, in your head, you categorize that individual in that MSc concepts, and it will change from day to day and sometimes even hour to hour. So, how the individual was in the morning might not remain the same in the evening. And that is why MSc changes over a time. In one sitting, how the person is versus after 1 hour, 2 hour, 10 hours, the MSc might be different. So MSc gives a very cross-sectional view of that individual. But at the same time, while you are talking about the person and taking the case history with that individual, that also becomes MSc for that, in that moment of time. And MSc is repeated over every few kind of uh, sometimes days, sometimes weeks, to understand how the person is progressing. So this another important aspect can be used even when the patient is mute, incoherent, and refuses to answer the question. And you might think that if the patient is not answering, how are we able to do the MSc? But you will learn later that how MSc is not just about the person, if they're able to communicate. Even if the person is mute, you get the idea by the looking at the person why the person is mute. Is it a mute of catatonia, or is it the mute of depression, or is it a mute of schizophrenia? So you will get to know uh, just by looking at that individual, their appearance, behavior, and that helps us understand. So MSC is all that. The patient doesn't necessarily have to talk to you. Description of patient's appearance, speech, action, thoughts, this is all MSC. It's not just talking to the individual. So these are the components of MSC. We talk about general appearance, attitude, behavior, speech, mood and affect, thinking and perception, sensorium, cognition, insight, judgment. So one by one we'll go into this. uh, General appearance and attitude and behavior. So appearance is the moment the patient walks into your chamber is from where the MSC starts. Even if the patient has not said hello to you, just by the way that they look, is you can start making your a mental status examination. The clinician describes the patient's appearance and overall physical impression as reflected by posture, clothing, grooming. So just imagine a person probably who has depression. So if they come in, first of all, they will come to you with a very slow-paced gait, and when they sit with you, their shoulders will be drooping. They might not even look directly at you. So those things, helps us understand what probably is going on in this individual's, mind. So you describe about the posture, you talk about alertness, clothing, grooming. If a person is probably depressed, they might not be, groomed properly. If the diagnosis, or if you're looking at schizophrenia, maybe then also the grooming might not be there. But in that case, maybe the clothing is also very, bizarre, in the sense that in the winter months they are wearing summer clothes, in summer months they are wearing winter clothes. So all those things become very, very important. If the patient appears particularly bizarre, the clinician may ask, has anyone commented on the way that you look? I mean, this is you talking to them and making them think how they are appearing, so that they can, again, have some bit of conversation. In that conversation, MSC is also being done. At the same time, you're also understanding the, you're reaching closer to your diagnosis in a way. Okay. Now, second is attitude towards the examiner. So if the person is, whoever the person is they, are they cooperative with you? Are they friendly, or they're over friendly? Are they attentive, interested, defensive, hostile, evasive, guarded? These are all categories which helps us understand what kind of individual is this person. Is this friendly nature coming out of any personality issue, or is this coming out from a pathology that we're looking at? Based on, we note down every individual factor that we are noticing, and then we collaborate and helps us, reach a diagnosis. um, in psychiatry, psychology, there is no, blood test to find out any disorder. There is no complete blood count which helps us understand that yes, this is depression or this is mania. So your MSC is that investigation that will make you reach closer to the diagnosis. Okay. So in that aspect, attitude, so appearance, I told you, attitude towards the examiner, how the person behaves, and how the person kind of reacts. Mention about the eye to eye contact, whether the person is able to look into your eyes, or while you were taking the case history, were you able to form any rapport with this individual, or it felt as if you were not being able to, maintain or achieve that rapport? It felt very cold and very distant. So all those things become important. Overt behavior and psychomotor characters describe both quantitative, qualitative aspects of patient's motor behavior. Motor behavior, like if I'm sitting, you might be, if you're looking at the camera, and if you're looking at me, I'm constantly moving, like I'm not able to sit still. So that is one of the ways how you can recognize um, what the psychomotor behavior is of the individual. So again, in depression and certain conditions, the person is very, very still, not at all moving. If the person is anxious, they might be moving a lot. If they have ADHD, they might be moving a lot more. If the person has mania, probably they will not be sitting at one place. They will be constantly, getting up, walking around, pacing around. So different disorders, different kind of movements. This one question: is it possible if a person is dressed well, enters the room with 100% confidence, they are cheerful as well, suffering from depression? Someone has answered also absolutely, but yes, absolutely correct. It's not necessary that what I'm telling you about, appearance and behavior, it, you don't have to take one aspect of MSC and reach a diagnosis. It is the, combining all the symptoms, all the findings that you have understood, and that is when you combine and reach a particular diagnosis. It cannot just be one aspect that you're looking at. Okay, I think I'll talk about all the questions later, otherwise ये खत्म नहीं हो पाएगा. Okay, so yeah, uh, you describe both the quantitative and qualitative aspects of patient's motor behavior, includes mannerisms, tics, gestures, twitches, stereotype behavior, rigidity, gait, pacing. Note down these things. If the person is making special gestures in the air, like moving their arms, so you just mention it, that patient is moving their arms in the air with no apparent reason. If there are repeated movements of the body, like movement of the shoulder again and again, if there are tics, if there are pacing, if they are not able to sit and they are continuously pacing in the room, you mention everything. uh, Psychomotor retardation, like I mentioned, the generalized slowing of the movement happens. um, Describe any aimless and purposeless activity. Again, it points us to certain kinds of disorders. We move on to the second aspect, is speech. Now, speech becomes important in two aspects. A, that it tells us about the uh, speech helps us understand the mood state also, but also helps us understand the thought process of that individual. So here, when we're talking about speech characteristic, you note down about the quantity of the speech, the rate of production, the quality of production. Then you break it down into quantity, whether the person is talkative, garrulous, voluble. So all these things mean separate things, in the sense that, like right now, I am probably talking at a higher pace than what I generally talk, because in my head I have to finish the talk in a limited period of time. So this makes me talkative. I'm in If I were to be talking like this with the same kind of quantity outside the setup, then my friends will say suddenly, Dr. Mantoj has become very talkative. He's talking a lot more at a much faster state, so rate of production is rapid. Garrulous, voluble is like how much loudness is there. Garrulous is more like careless, and sometimes almost not looking into the errors that they are making. Unspontaneous means, like the kind of sentences, they are unconnected, and they are just coming, or maybe they are just not talking at all. Like you ask them a certain question and you're not able to elicit any response from them, so it is more unspontaneous. You have to keep on asking the questions again and again. So quality wise, whether they are pressured, again, my if I am talkative, if I my rate of production is rapid, then quality wise also it seems more like a pressured speech. I'm talking in a way that it's more pressured, lot of information given in a very small time frame. So a lot of pressured speech, hesitant, monotonous, dramatic. Dramatic is taking long pauses, or sometimes even using the words in a different way, which makes the whole quality feel very dramatic. Monotonous, there is no change in the intonation, it seems very monotonous. Speech impairments, like such as stuttering or stammering, should also be included in this. Third aspect is mood and affect. Now, mood and affect are representative of the emotional state of the individual, whereas mood is the more pervasive and sustained emotion that colors the person's perception of the world. So it describes more like how they have been for the past couple of days, weeks, months, how they have been feeling throughout. In the description includes comments both on the depth and the intensity, duration, and fluctuations, and it is always better to describe them using such adjectives like depressed, euphoric, irritable, angry, anxious. You mood is something which you are eliciting in that individual. You also get at the same time, again, like I had mentioned, you MSc is not cross sectional in the sense that I'm going to just focus on the mood right now. While you are talking to that individual in the whole MSc, you will get to know about this individual. So it is more You will start understanding that this person is euphoric, irritable, angry, anxious, so you'll get to know the mood of that individual. When you talk about the affect, is what, it feels as if this person is able to match to that mood or not. Okay. So it is the present emotional responsiveness, and you can look at the facial expression. You can even sometimes ask a very direct question to them, so that helps us understand what they are feeling, what they are, and how is it matching to the responsiveness to that individual. So, like, you were talking about the mood, you talk about whether it is labile, stable, fluctuating, and alternating between extremes. Now, when you talk about the affect, we talk about the amount and range of expressive behavior may or may not be congruent with the mood, in the sense that how they might be talking about themselves over a period of time, and how they respond, or how their facial expressions are, they might not match at certain times, or they might completely match. Let's say in cases of depression, like, someone asked that question, overconfident and cheerful and everything, but when we talk about how they are feeling, they might say that I'm feeling sad. But on the face, you might see a little bit of smile, and everything does not match to what they're saying, but you have to then note down things accordingly. Again, affect can be described within normal range, or is it constricted, blunted, or flat. These again is like understanding the affect, in the sense that if I'm talking about something happy, I will also be, smiling. I would also be talking about with a with the voice which seems more, in tuned with the emotion. But sometimes people don't, when they are going through certain mental health conditions, it might not appear that way. They might be talking about, getting a promotion, but they're talking as if nothing big has happened. Or they might be talking about divorce or separation or death of a family member, but they might be not be showing that kind of a, range of emotion, along with the kind of conversation that they are doing. So that is where you can describe whether it is in the normal range, constricted, blunted, or flat. Appropriateness of effect, that is what I was talking about, whether it feels appropriate or more congruent or not. Appropriateness is considered with the patient's emotional response in the context of the subject that the patient is discussing. So again, appropriateness, helps us understand how they are, seeing any situation in their life. This aspect needs more of a detailed evaluation, thinking and perception. This is where most of us find a lot more challenge in understanding what the person is going through. So we divide it into certain aspects, and the thinking and perception is divided. Now, thinking, you divide it in the way of form of thinking. Okay. And here we talk about formal thought disorders at times. So form of thinking is divided into productivity, in the sense that when we are talking to that individual, is the individual, um, the kind of, so thought is then represented by speech, and that's why I was talking about speech being a very important tool for us to kind of understand the mood as well as the thought. Now, if the thought is uh, in flow with the conversation, then there will be a good amount of, conversation happening. The choice of words, the number of words in the sentence, the number of sentences, so everything will happen in a flow. So how is the production? So is there overabundance, or there is paucity, or sometimes flight of ideas? So flight of ideas will be like, I'm starting a conversation about one thing, at the same time I also start talking about, without the other person realizing that I have already shifted in my conversation. I started with about talking about the weather of the weather of Gurgaon, and suddenly I'm talking about the financial condition that I am facing, or I'm talking about what happened at home. So without any, or what I'm planning to do in the couple of weeks ahead. So a lot of ideas, a lot of thoughts are coming in, and sometimes called as racing thoughts. So racing thoughts, and then expressed as flight of ideas happening. Continuity of thought is like, when, if I were to ask an open-ended question with someone, or if I were to ask a question, then we get an answer through which we can deduct some information about the individual. Whereas if there is no continuity of thought, then it's very difficult to understand what the patient or what the person is trying to express. And that is where we call loosening of association or loose associations. Okay, so there seems like a lack of cause and effect in the patient's explanations. The When there is sometimes illogical thinking present, where they give up certain explanations which does not form any sense or does not form any logic in the explanation or the cause, let's say, of whatever they are trying to explain. So it seems very illogical. Tangential and circumstantial is, let's say, if I were to ask how you're feeling, and they start talking about everything else but not talking about how they are feeling. And in that conversation, it seems as if though we are reaching that point where they will reach and they will tell us about how they are feeling, but it always seems to evade. So the thought never comes to the question and everything else apart from the question, but seems as though they are going to talk about what the question that has been put forward to them. Circumstantial is very similar to tangential, but it reaches a conclusion where whatever question is asked to them, they might reach the answer to that question, but after a lot of information provided, which is irrelevant to the question given to them. So that is what circumstantial means. All these things, the more you practice, the more you kind of talk to the individual, talk to patients, talk to a lot of people, that is when you will understand what these all mean. Language impairment is a completely different thing. It's so, in fact, difficult for us also to explain it to you, because a person who has impairment in the language is using their own kinds of formation of either words or combining letters or combining word in a way that makes sense to them but not to the examiner or not to the person who is interviewing the individual. So it can be in the form of word salad, it can be in the form of clang associations and neologisms. Neologisms means a new word that the person kind of mixes up, and it comes from the same it from comes from the words that make sense to most of us, but they have uh, they use it in a different aspect, in a different way, to describe what they want to describe. Word salad is where two different words are mixed together to to represent something which again means something to this individual, but for an examiner or for any regular individual it will be very difficult to interpret or to understand. Okay, so that is why it becomes almost incomprehensible or incoherent to the examiner. Next comes is the content of the thinking. So here we previously talked about the form of thinking, how the thinking is formed in that individual's mind. Now we are talking about the content, what they are thinking about, how they are what they're communicating about what they're thinking. So it could be in the form of preoccupation about illnesses, environmental problems, obsessions, compulsions, obsessions, or plans about suicide, homicide, hypochondriacal symptoms, specific antisocial urges on impulses. So this forms the content of whatever thought process they are coming up with. It could be anything apart from this also. Okay, but most importantly, this is where generally we kind of in the MSc we try to understand what kind of content they are coming up with. Okay, thought disturbances are in the form that the content of the thought helps us understand the belief system in that individual. So content of so that is where delusions come in now, because there's a disturbance in the thought pattern. So content of any delusion system, its organization, the patient's convictions as to its validity, how it affects their life, uh, persecuted illusions, isolated or associated with pervasive suspiciousness, mood congruent or mood incongruent. So delusions are false beliefs and false beliefs that the individual holds, and they talk about it, and mm, uh, how much it starts affecting that individual's life is what you will get to know through the delusions of that individual. And when you go into the depth of the discussion, depth of understanding then there'll be whole kind of scenario made in the person's, in the person's history, so to speak. And it starts uh, kind of impacting their lives. And delusions then are of multiple types, and again, depending upon the diagnosis that we're looking at, delusions can be delusions of poverty, nihilism, delusions of persecution, delusion of reference, delusion of grandiosity, delusional misinterpretation. So all these delusions are, kind of held by the patient very firmly. A person, one individual can have multiple delusions also at the same time. Delusion of reference, persecution sometimes goes hand in hand. Delusion of reference, delusion of grandiosity can happen. Delusion of nihilism and poverty can happen hand in hand. So multiple times, multiple delusions happen. Sometimes isolated delusions also happen. A delusion of infidelity, erotomanic delusions. So various categories of delusions happen. This is the example that I was talking. It's very difficult for us to even talk about it. So that is why we kind of give examples, because if I were to even bring up the example just by not reading, it will be very difficult, because our brains work in a way that we want to explain things in a certain way so that it is understood by the other individual. So here, this example of loosening of association, you'll understand what this person is going through. So the patient says, मैं नरसिम्हा हूँ क्योंकि केरला में पानी जमा हो गया है और श्रीदेवी मर गई है. Does not make any sense, does not make any understanding. It seems as if there are three different information, and the information is also not connected with each other. So another thing, the doctor here asks, दवा बंद कर दी थी. The patient says, अस्पताल में कोई बंदे देखे हैं, आप बताइए, आपको जो हुक्म होगा सर आंखों पर, जितनी दवाइयाँ, मेरे में दवा, मैं दूध बनाता हूँ, जो खाना है मैं खुद चुनता हूँ. ये घास खाई ना तो रामायण में ना सीता ने रावण को बोला ये घास, समझ जाओ ये चूहा ना, फिर क्या खाएगा. So a lot of, in fact, for me to even read and to talk makes my mind kind of, it's very difficult, because for me, or for any person who is not experiencing any disorder in the form of loosening of association, will have very difficulty understanding what the person is trying to say. Another examples of tangentiality. डॉक्टर सेज, नमक और शक्कर में क्या फ़र्क होता है. पेशेंट, नमक अगर ज़्यादा हो गया तो आपको रखना पड़ेगा, शक्कर का पता नहीं. सो द पर्सन, द क्वेश्चन वाज व्हाट इज द डिफरेंस बिटवीन द टू, बट the patient talked about the two but did not actually answer the question that the doctor was asking for. Another example, did you sleep well last night? So I usually sleep on the sofa, but these days I slept in a bed. So again, they're talking about where they are sleeping, but not exactly how the sleep quality was. Are they sleeping well or not? So the topic was sleep, but they kept beating around the bush. Another example of punning is, क्या काम करते हो? So the patient says, sir, अंधेरी का कपड़ा बेचता हूँ, अंधेरी रातों में तूफानी राहों पर. So the patient just picks up the place Andheri is a place in Mumbai, and from that word they started rhyming it. Andheri Raton mein Tufani Raon Par, which is a part of a song basically. So sometimes people do come to us and talk this way. Clang association. Example, भाभी तुम क्या कर रहे हो, तनुजा हो गया सो गया खो गया. So clang, गया 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 गया. So this kind of rhyming of the words sometimes happen, but here specific word is being used again and again. Delusion of grandeur, flight of ideas, prolixity. Here is an example which actually is a song. I don't want to read the whole paragraph, but if you can, then do listen to this basically song from Bollywood. जो सोचे जो चाहे वो करके दिखा दे, हम वो हैं जो दो और दो पांच बना दे. The song is wonderful. You must enjoy this song. It has a good music also, but it talks a lot about grandiosity along with flight of ideas and prolixity. So just like a homework for you to kind of listen to that this song and understand the fun of this song. Um, Next comes is perceptual disturbances. Now, perception are the five senses or special senses that we have: eyes, nose, taste, hearing, touch sensation, and also joint or proprioception. So, in every aspect, there could be disturbances in the form of either hallucinations or illusions. Okay, hallucinations are when the external stimuli is not present and you experience that in that particular sense, whether it is auditory, visual, gustatory, olfactory, or tactile, or proprioceptive. So let's say if I'm hearing voices, but actually there is no voice in the surrounding. So there's no stimulus, but I'm still hearing the voice. So that is a hallucination. Whereas in illusion, there is an external stimuli, but the uh, the perception that the individual has is not exactly what is supposed to be. Let's say if a person in the darkness sees a rope and understands it to be a snake, that is the illusion that the person is experiencing. That is not a hallucination, because in reality there is a rope lying, and that the illusion was of a snake. So similarly, hallucination would be seeing a snake when actually there's nothing in the room. Okay, whether patient hear voices, sees visions, content, sensory system involvement, circumstances of occurrence. So in these aspects, you should mention it down. Okay. Content is also important because it will help us understand the delusions also a little better. Sensory system involvement, like I told you, the special senses. Circumstances of occurrence, sometimes there are certain types of illusions which happen in a specific situation itself. I've come across a very interesting individual where the moment the ceiling fan was switched on, that the person would start hearing voices, the auditory hallucination, and the moment the fan was switched off, the hallucinations would also disappear. So again, interesting, thing to know. Hypnagogic, hypnopompic hallucinations, these are the only two physiological hallucinations which even people with no pathology can also exhibit. While just before sleeping, while you're slipping into the NREM or REM sleep, or just when you wake up, is when you also sometimes experience hallucinations. Then there is another aspect of thought broadcast where people experience certain symptoms, like they talk about how they uh, believe that their thought is being known to other people without them actually talking about their personal thoughts. So this is something that they experience, that their secrets are no more secrets and everything is known to everyone around them. So that is called as thought broadcast. There's another aspect which is called as thought withdrawal and thought insertion. That specifically means that through some thought insertion is like through some alien force, someone is putting the thought inside my head. This is not supposed to be my thought. So that is an example of thought insertion. Thought withdrawal is like through an alien source, someone or something is taking away my thoughts, so I'm not able to think clearly, and that's why I am left with no thought. So that is thought, so thought broadcast, thought insertion, thought withdrawal. There are other aspects which are to be noted, like depersonalization and derealization. Here, there is detachment from the self or from the environment. So when we talk about depersonalization, there is more of feelings of detachment from the self, and derealization when it feels as if the whole environment is uh, as a simulation, so to speak. So it does not feel real, as if everything is unreal, and that kind of gives these people a lot of anxiety. We go into the kind of higher mental functions in a way. Sensorium cognition, alertness can be assessed by understanding the awareness of environment, attention span, stupor, lethargy, fugue state, coma. So that is like the stage of awareness and alertness that the individual has. Whereas coma is where the person is obviously unresponsive. Then you are not going to indulge in any. Obviously, the MSc ends there in a way. But if the person is aware of the environment and the conversation is happening, that is what you have to kind of mention. You have to ask certain questions around it. Similarly, orientation, time, place, and person. Very simple questions: what time of the day, date, and month and year is the patient able to tell everything correctly? Which place the person is right now? Uh, whether the person understands whom they are talking to, or any relevant person who they can count on, who can talk about. So that kind of helps us understand the orientation. Now, when we talk about sensorium cognition, this helps us both in patients with psychiatric disorders as well as sometimes with neurological disorders. So we are looking into helping us differentiate between the two aspects. So orientation to time, place, and person. Sometimes they are not intact in delirium, like I told you earlier, but sometimes it can also happen in acute withdrawal from alcohol, let's say. So we, with the history that you have gathered, we get to see a person who has disorientation to time, place, and person. If the history was there of alcohol use, then we are probably looking at alcohol withdrawal. Or if there was a head trauma in the history and that the person was examined by you and they are experiencing disorientation to time, place, and person, then the diagnosis would be to look into, do certain investigations like MRI, CT scan to rule out any, traumatic brain injury. So these questions, they are not irrelevant. You have to kind of, talk to them, understand what is happening. Concentration calculation, subtracting serial subtraction, basically from 7 from 100, and keep subtracting the sevens. So serially you keep asking the patient to subtract. Important here is to you also know the answer to it, otherwise you will not understand when the patient is right or patient is wrong. So assess where anxiety or some other disturbances of mood or concentration seems to be responsible for a difficulty if it is observed. So ideally, a person with a decent background of, education and calculation will be able to do that. You can also sometimes simplify by asking the patient to serially subtract 3 from 30. So that is also possible if you think the 7 from 100 is difficult for that individual. So there's another way to assess that also. uh, Memory is divided into remote, recent or past, and recent memory. Okay, or immediate retention on recall. So remote memory is childhood data, personal, information that you gather from this individual. Recent is like recent past memory is past few months. Very recent is past few days, and immediate retention is ability to repeat six figures after examiner, first forward and then backward. So uh, uh, you kind of tell the patients some certain numbers, six figures in a certain order, and you ask them to repeat with you and then ask them to repeat it backwards. That helps us understand whether they are able to have immediate retention or recall or not. Fund of knowledge, level of formal education, self-education, estimate of patient's intellectual ability and basic functioning. These are the aspects that we are looking at. We can ask certain questions related to political system, or depending upon the socio educational and cultural background, some questions related to that, so that you're not asking a person which they might not be able to answer. If someone was to ask me all the festivals of south of India, probably I'll not be able to answer that. So that does not mean that I don't have fund of knowledge. I'll be able to talk about some festivals, but not all of them. So similarly, you have to look into the education as well as socio-cultural background. Abstract thinking is basically what kind of is the patient able to form concepts in their brain, and can be tested by similarities, differences, absurdities, and meaning of simple proverbs. Like, you for example, you talk to them about finding similarities between an apple, a banana, and an orange. So what kind of similarities they can talk about, what kind of differences they can talk about. You give them simple proverbs and try to understand what kind of meaning they derive from that proverb. That also helps in understanding their abstract thinking. Now, insight is degree of personal awareness and understanding of the illness. This becomes important for a lot of reasons. How much participation the patient and the individual will have in the treatment, how much regularity and how much consistency they will have in follow-ups, how much they have understood about the illness, how serious they are about their illness, everything, how well they will progress with time, when they have an insight. So this helps us understand a lot of future course of the problem, or what happened up until now. That also can be understood by the insight. So grade 1 insight is complete denial of the illness. Nothing is wrong with me. I don't know why I'm here. My family has brought me here, so I don't know. I'm just sitting here talking to you. So that is complete denial of illness. Slight awareness of being sick and needing help, but not denying it at the same time. So yeah, maybe something is not right with me, but maybe I don't need any treatment. I don't know. I was asked to come here. Yes, something I feel, maybe I'm not sleeping well, or maybe I feel a little tired, but that's okay. And they kind of explain it by attributing it to something else. Maybe the workload was a lot more, so I could not sleep. So that slight awareness of being sick, but and needing help, but denying it at the same time. So like saying, ki, okay, but I'll sleep. Okay, I'll do something about it. So that is like grade 2 insight. Awareness of being sick but blaming it on external factors. A lot of times people are in this phase even when they come willingly in the hospital. I'm not okay because everything is going wrong in my life. This is bad, this is bad. A lot of blaming on the external factors. Grade 4 is awareness of being sick and understanding the role of internal factors. Now here the person is able to understand that something probably is not okay, but they're still not able to have that complete understanding of the illness. Between grade 4 and 5, there is that thought that scientifically probably they also understand in grade 5, and intellectual insight comes. Okay, this is probably what is wrong, and I need to correct that, and I would like to take the treatment for it. But true emotional insight is when they understand it scientifically, but they also understand their participation in the treatment, how they have to also work towards it. So that is what true insight is. And we have Dr. Samir Parekh here, sir. Would you like to read some questions? I have not read the questions so far.
No, I think the most important thing in life is intellectual and emotional insight. The bottom line of life is an insight. If you have insight and if you don't do something about it, then it's not insight. And it's not about illness, it's about life also. In life, have insight. Before we say something, do something, have insight. And then do something about your insight. Insight के बिना तो कोई बात ही नहीं.
We'll take a 5 minutes break here because someone is asking probably.
Yes, you haven't got a break.
No, we have not, because
That's because I did not serve you chai.
No,
I'm going to. So they call me the chai person for a reason. They just added the air and called me a chairperson. Otherwise, I'm very much a chai person. So I'm going to give them some chai, everyone, and I'll get a chai for everyone. And you all take a, 5 minutes break. You all take a 5 minutes break. I give him good old chai. And I'm not answering any questions today. I'm just very tired. Bye.
Thank you. So I'll see you guys in 5 minutes. I just wanted to. I think my topic is almost over. Kamna can take over.
उनको तो ब्रेक दे दो यार.
बच्चों को. Kamna, would you like to add anything here? अब तक में?
I think we're going really well with this. A lot of things that you said were very important. And I think before we move to the second part of the presentation, understanding these questions and what to take up in, take up in history becomes really important, because then that helps us establish the alliance that we're going to be talking about. So I think that's great. And what Dr. Parekh said, insight is very important for all of us.
Okay, so I'll read a few questions in between. Like अभी 5 मिनट का break है. So people with high anxiety or trauma have high alertness. Will that be a correct observation? Yes, they are sometimes in the hypervigilant mode, and that could be very exhausting for that individual. It's a good observation. 5 minute break. Sometimes people on hearing water flowing feel there are people fighting outside. When the water stops, the fight stops. This would be a hallucination. Fight happening is a very strange kind of example that you have given. We need to probably ask a lot more questions here. When we talk about fight, is the person who is listening to the water flow is also thinking about it, is feeling about it, or listening to conversations in a fight way, or seeing something, and when the water stops they're not seeing things or not hearing things. So the question probably needs to be asked more. Thought broadcast is not an disorder of perception. It's a thought disturbance, so to speak. It's a different category altogether. Need a break. I'm reading more like need a break. Okay, okay, okay. Okay. We're giving a 5 minute break, but I want to finish it.
मैं ब्रेक दे दो.
दे दिया है. मैं क्वेश्चंस पढ़ रहा था बस.
नहीं, ब्रेक दे दो, चलो. I'm taking him for tea. Nobody talks for 5 minutes. You get
Okay,
a
sir.
break. Yes, yes, I'm going, giving him some chai with, what are those called? वो बीच में जो jam लगी होती है?
Jim jam.
And some, yeah, those biscuits with the jam in between. We'll be back soon.
Yeah. So in the meanwhile, I'll take up some questions till Sir joins us. We've almost reached the end of MSc. So I think that's important that we also go to the next part of our presentation. Just taking a few. Someone's asked, what is the doctor's name? I missed it is Dr. Mantosh. Okay. What if the information given by the patient and others, like friends and family, contradict? How can we know which one is true? Sometimes we do get information from informants, which are friends and family, and very different from the patient, which can be contradictory. We also have to understand that we have to corroborate the information that's given and find what are the similar points, and also look at the contradictions in itself to understand where are we going with this, right? Um, yes, I'll take a few questions then. How do you get to know whether a patient is lying about their problem? See, we also have to understand that sometimes patients may not be telling us everything at the first go. Hence, when we do case history or even MSc, or when we are doing this, it's not a process that we just do once. We do it multiple times when we meet the patient. Every time we do it, we do ask more information. If we're not sure of whether they're lying or not, like I said, you have to corroborate that information with the informant then. Um, Also, when someone, if you remember in the beginning, we also check for the reliability of information. We also say sometimes that the information we have may not be reliable. So that's also important for us to make a note in our case history in MSc. I think, should we go ahead or shall we wait for Dr. Mantosh? Mm, any other question? Can the patient answering non-accurately for image purpose result in false diagnosis? Yes, if the information we get is not correct, or let's say is not what we actually need, it can lead to a different diagnosis, which is why we never give a final diagnosis. We always give a provisional diagnosis. It always changes depending on what new information we have. Could we change? So Dr. Parekh has very beautifully explained that insight is very important for all of us. I think these are the different levels of insight that we have, and Sir has already explained this. I think we can possibly move to the next slide. Someone from the back end will have to help me. Yeah. Then we talk about judgment. Judgment is also taken in order to see whether the patient that we are assessing, are they in sound judgment, or are they able to make judgments about themselves, about about their social responsibilities, as well as test judgments. When we talk about personal judgment, it's about regarding themselves and their future. What are whether are they fulfilling their roles and responsibilities? Are they taking care of themselves? Are they able to make those associations that need to be made within their future, what they want to do? Social judgment is more of the subtle manifestations of behavior that are harmful to the patient and contrary to be acceptable in behavior and culture. So, are they socially appropriate? Are they showing behavior that is socially appropriate in a particular situation? Test judgment is also we assess for test judgment. When we do personal judgment and social judgment, we observe it, whereas we assess for test judgment. When we're doing this, it's basically to see what the patient would do in an imaginary situation. So one of the questions that we ask is that, say for example, I think Sir is here. So why don't you take
Yes.
over for test judgment?
Yeah. So, okay, you described about test judgment is a scenario that you give the individual, and then you ask them what would you do in such a situation. But quite frankly, honestly, nowadays we are not doing all these judgments as of now. Judgment of test, personal and social judgment. करते नहीं है ज़्यादा हम लोग, right? I'll skip. If you listen carefully enough, I'll tell exactly what kind of person they are. Sit back and listen. So this slide is most important, and as therapist and would be therapist, this is the most important thing. Just listen, ask certain questions, and then listen. I think I'm done with it. Now you start.
Okay.
That was the
Thank
last
you,
one.
sir. So, yes.
I'm here.
Now we're going to, yeah, you're here? Okay. So, now we're going to talk about the therapeutic alliance in clinical practice. Now, why this is part two of our presentation is because as soon as you've gotten all the data from your case history, you've gotten all of the information from MSc, now we establish the therapeutic relationship. Can we go to the next slide, please? When we're talking about what, it's very important for us to understand what is a therapeutic alliance. When we're talking about a therapeutic alliance, it's the working alliance between a clinician and the client. It's between the therapist and the patient. It's considered the most important aspects of the therapeutic process because it's important for us to establish the treatment outcome and the treatment goal. Now, when we're looking at a therapeutic alliance, at the center of this alliance is the therapist and the client, whereas the therapist acts as a facilitator and helps the client achieve their goals and provides what we call evidence-based treatment and interventions. Whatever treatment or intervention is being given is evidence-based. It's backed by, oh, hello.
The gym jam was remaining. Chai is already here.
Okay.
Wow.
Now you can continue.
Yes. Thank you. Thank you. Carry on. Carry on.
Yeah. Like I said, the therapist acts as a facilitator in this relationship. It is a relationship between the client and the therapist. It is not a friendly relationship. It is actually what we call a professional relationship. A lot of times people think that therapy is like chit chat. Therapy is not like chit chat. A therapeutic alliance has a goal in mind, and this alliance is the ground at which the therapist constructs this relationship in terms of what is the treatment aspect, what are the interventions that we have to use, what is the goals. Can we go to the next slide, please? Okay, when we're talking about the therapeutic alliance, Borden in 1979 conceptualized this as a triangle, right? The three main components of this are the what we call collaborative goal setting. Goal setting basically implies that there is a mutual understanding between the client as well as between the therapist about what are the strengths and needs and what is the goal that the individual or the client has come into therapy for. The next is shared decision making. It's very important for us to understand that in a therapeutic alliance or in a working alliance or a therapeutic relationship, there is no power dynamic in terms of what we say that the therapist does not make decisions for the client. It is a shared decision making process where the clinician and the client work together to make these decisions with the help of what we call the bond, or what we're essentially focusing on is the alliance, which is, it's more abstract when we talk about it. It's more like an emotional component here. This bond, or what we call the alliance, is basically we're creating a trusting relationship between the client and the therapist. It is the establishment of this is the fact that there is a trust moving from the client with the therapist as well as from the therapist to the client. Now, when all three of these come together is when we look at what a therapeutic alliance is. Can we go to the next slide? Like I said, three main aspects of a therapeutic alliance is the tasks that we have at hand, which are both activities which are covert and overt, in which the client must engage to benefit from the treatment. Now, let's say, for example, we have a client who has come into a therapeutic process who would say that they're very anxious in social situations, or they have a phobia. One of the tasks could be, exposing them to that phobia. Now, this is important in our therapeutic relationship, that we define the tasks. We also define goals. These are general objectives towards which the treatment is directed. Now, these goals are not just made by the client, they are also made by the therapist. There are some client goals and there are some therapist goals, and these are mutually discussed. When you discuss your goal, it strengthens the alliance between the two, and there is a direction towards the therapeutic relationship. Like I said, the bond is the emotional component between the relationship between the client and the therapist. It's very important for us to understand that in order to establish this therapeutic alliance, you need to have a few components. When we talk about these components, each of them are essential in establishing what we call a good therapeutic relationship. Number one is empathy. Empathy is the ability for an individual to step into another person's shoes. It's the ability to put things in perspective. As a therapist or as someone, as a counselor, having empathy is really important so that we can make the therapeutic relationship very, very strong, because you're able to put yourself in the shoes of the other, which is essential for a good therapeutic relationship. Next is unconditional positive regard. We've all talked about this. It's very important that as in our alliance, there is unconditional positive regard, because if there is a conditional positive regard, there would be problems within that relationship, because the client may feel that they won't that they will only get a positive regard if they do something which is not what we want them to feel. Trust. Trust is a very important key factor in any alliance, not just a therapeutic alliance. But why it becomes even more important in a therapeutic alliance is because this person or this individual is trusting you with the issues or with the problems that they have. They are trusting my judgment and my skill. And I'm also trusting that whatever I'm saying, they're going to take in for them. So trust becomes a two-way process. Genuineness. I think one of the key aspects or a key component of a therapeutic alliance is being genuine. Sometimes, if let's say in a therapeutic relationship, your client cracks a joke, it's okay to laugh. It's okay to have genuine emotional responses. If we're not going to be genuine in our emotions, genuine in our thoughts, you're not going to be able to have a good rapport, or you're not going to be able to have what we call a trusting relationship. For a therapist, or for anybody, in fact, for any alliance, flexibility in our approach matters. Am I, as a in my therapeutic alliance, sometimes we would have to change what this alliance looks like. When I say change what this looks like, it's the flexibility. Sometimes you would have to give a more softer ear. Sometimes you'd also have to take a more back seat. Sometimes in the alliance, you'll have to become what we call not just the facilitator, but also someone who takes more charge or allows the client to take charge. So flexibility in our approach becomes even more important as a therapeutic alliance. Self-awareness. For a therapist or in a therapeutic alliance, self-awareness becomes important because we need to know our strengths and our weaknesses. We need to know what are our goals, what are our values that may be coming out in this alliance. What strength can I play on with a particular client? What weakness comes out for me in this, and how is it impacting the therapeutic relationship? Being honest about it is also very important. Intellectual competency, as a in any relationship or rather in a therapeutic setup, intellectual competency is important. Sometimes it's also okay for a therapist to say, this may not be my area of expertise, rather than going and doing something that may cause more harm, right? Because every therapeutic alliance can differ based on approach. So having that intellectual competency, knowing when to shift, when to be flexible, that also important. Active listening and communication. um, Active listening, when we talk about it, it is not just hearing what the other person is saying. Active listening also means looking at their nonverbals. I think I'll come into more aspects of active listening. Communication. Our job is to talk, listen, communicate. Communication is what holds this relationship together. The environment also matters. We do not have a therapeutic alliance or a relationship in what we call non-formal environments. So therapy cannot be done in a cafe, it cannot be done in a park. The environment also sets the structure of a therapeutic alliance. There's a reason why the therapist would sit across the client or sit besides the client, depending on the approach that we take. Reflection. A therapeutic alliance, when we talk about it, is not just for the client. Sometimes in this relationship, there are certain self reflections that come up. We also have to learn to reflect how our behavior may have caused a change or caused a thought in the client. So having reflectivity or having reflections for both the client and the therapist is important. Now, when we put all of these together for ourselves within the therapeutic relationship, when you put empathy, trust, genuinity, it becomes what we call a strong relationship. Next. Now, there are certain variables in a therapeutic alliance. Now, when we talk about these variables, it's very important to know our own variables. The first is a professional variable. This essentially talks about the theoretical orientation, our trainings, our experience, our a therapist's view on psychotherapy, how neutral we are, how active we are. So these are all professional variables that would come into a therapeutic alliance. Like I said, um, if our orientation is, let's say, more clinical in approach, or let's say we're coming from a psychodynamic orientation, our therapeutic relationship differs. For someone who may be a more solution focused orientation, again, the alliance would largely differ in the way it is going. Relational variables. When we talk about relational variables, we're talking about our own empathy, our unconditional positive regard, respect, warmth, genuineness, attachment styles. All of this also is, it also helps to understand the how the therapeutic alliance may be formulating. No therapeutic alliance looks the same. It looks different for everybody. So we also need to be in touch with what we're also experiencing for that relationship to get better, and also understand where it's coming out for us. Age matters. The next variable talks about demographic and diversity variables. This is very important for us to understand that our demographic and diversity variables also impact the therapeutic alliance. Simple example, a lot of people find it difficult to have a psychotherapist or a therapist who may be uh, a lot older in age or a lot younger in age. So, age can make a significant difference in the therapeutic alliance. Gender also can play a key role here. A lot of times, same sex or same gendered therapists and client may have issues, opposite genders may have issues. So, it really largely depends on the client, but we also need to understand that these variables do come between a therapeutic alliance. Race, ethnicity, values, client therapist similarities. If they're from similar social circles, then it's not possible. All of this becomes very important when we're establishing the therapeutic alliance. Personality variables includes our attitudes, our traits, our flexibility, our adjustment capacity, trustworthiness. All of this becomes this this becomes important in the therapeutic alliance, because it's not just the client that is bringing themselves. We are also bringing a large part of ourselves in the therapeutic alliance, and thus it's important for us to know that is my attitude or is my, let's say, trait coming up within the alliance, which may hinder is it a hindrance for the client, or rather is it actually helping the client? So again, reflection becomes important. Next, essence of can we go back, please? Yes, essence of a therapeutic alliance. Now, so far we've just talked about what this, what does it look like, what are the things. Now, the essence of a therapeutic alliance is essentially to establish comfort for the client, so that they feel that they can share their problems, they can share what they've been feeling, what they've experiencing. So at the core of this is that there is a trustworthy relationship that they are taking back with them. Ensuring commitment to establish this meaningful relationship is based on mutual respect. If I'm showing respect towards what my client is saying, if I'm showing respect in my behavior towards them, I will be able to form a rapport a lot better. So there is that feeling that I'm not judging my client, I'm not judging what they're saying, so they can come out more easily. In any therapeutic relationship, there will be challenges. A lot of challenges come up. Sometimes your client may not agree with what you're saying. Sometimes you may not be able to understand from their perspective. But that doesn't mean we break the relationship. It is working through these challenges that comes up as a process, because therapy is a more uh, process oriented approach. We are looking at outcomes, but working through those challenges that come up for both the client as well as the therapist is very important. um, to have empathy, warm, and build like a healthy productive identification, because our goal is to help the client grow. and not create a sense of dependency. So we have to make the client accountable. We have to teach them responsibility of taking onus of their own growths and failures and sharing it with them. So I think this is what's important for a therapeutic alliance, that you build comfort, you show that you are committed to want to help them, you work through the difficulties, and with empathy and warmth also make them independent to take responsibility of their own problems. Because whenever someone comes in and you're helping them for with a particular situation, by listening, we also need them to further go ahead, right? Now we talk of the interesting aspect, which is stages of therapeutic alliance. So let's go to the next slide. Next. Yes. Okay, we've gone way back. Go back. No. Can we go back to stages of a therapeutic alliance? Yeah. Can we go to the next? Next. Yes, now stay here. Okay, thank you. We are talking now of what we call stages or phases of a therapeutic alliance. When we broadly look at a therapeutic alliance, there are three phases that we look at it in. The phase one is the orientation. In this is the initial stage of the therapeutic alliance. This is when the client comes in the first few times, you're orienting them to what the therapeutic process looks like. You've probably already done the case history and MSc. You've decided, let's say, you ask more questions about the client. You ask them what are the things that they're experiencing. Now, here is where the client and the therapist are making an agreement to take out some time in the week or 2 weeks or whatever you decide and spend energy on specific goals. So, in the orientation phase, we also have what we call goal setting. We decide goals that, okay, this is what I want to work on. These are the things that I've been experiencing. This is how I want help from. So, in the orientation phase, the perception of the therapist and the intensity for the client to change becomes very important. We also assess that, okay, is the therapist and the client a good fit for each other? Are we going to be able to work together? Is my orientation going to help this client, or do they need a different approach? So it becomes very important that we're orienting ourselves with the client's difficulties that come in, as well as with the client as to what are the things that they can expect, what will be done, so on. Next comes, and once you've formed the orientation is also important because it helps in rapport formation. If we form a good rapport, if we're giving that sense of comfort, we're giving that sense of commitment, we have that mutual trust, our orientation phase would probably then move to our next phase, which is working phase. The working phase is when the therapist allows the client to take charge, talk about things, and notices patterns. You gather information, you consolidate all of that data, you look at the different triggers that are coming up. Let's say a goal is there to reduce anxiety, or let's say overthinking. A lot of us come up with this feeling of that I've been overthinking so much. In the working through phase, the client will talk about, I tend to overthink at work, I tend to overthink at home, it makes me feel like I keep thinking about the future. It's this phase that the therapist notes down all of these cycles. The repetitive interaction that you're having with the client also shows that, okay, what are the commonalities or what are the trigger points for my client? And you the therapist then takes up the role of the facilitator and facilitates for the client what are the different tools, what are the techniques, what are the approaches that you can use in a particular pattern. Now, let's say, for example, when someone's feeling anxious, and we've noticed that their anxiety usually comes up in social situations. So the therapist would then, summarize that I've noticed that there are certain situations where you feel anxious, but to me, what I'm seeing that it's with certain people who may act as authority figures. Now, how does the client respond to this also becomes a part of the working phase. In the working phase, you also help your client with getting a lot of techniques which they can use outside. So let's say grounding technique. We introduce a grounding technique in one session. We do it 3-4 times with the client. We ask them that next time when you're feeling anxious outside, continue to do the grounding technique. Then the client comes back and tells me that, okay, this worked for me, this didn't work for me. So it's a very to and fro process. Post the intervention that you've used in the working phase and you've got a good outcome of it, you reach the end stage where the therapist and client can now recognize as each other that the client has become autonomous. They are independent of whatever they're feeling. They are able to manage themselves, and the facilitation by the therapist, let's say, or the intervention has worked, and now the client feels capable or stable enough to terminate this relationship, right? And sometimes what happens is that when we see that the problems that they came with have been solved and all other things that are coming up for them have been solved, then we terminate the therapeutic relationship. There are certain times where we may terminate without the effectiveness of the intervention working. And sometimes what happens is that even after we terminate, the client wants to come back because there's something else. So there is no set timeline or structure to what we call orientation, working, termination. It happens as a process. So it keeps going back and forth for different clients. And also we need to understand that we, as a therapist, when our working through phase might extend longer than what we expect, because we may be working on one goal that I thought was important, but now my client has come up with a new goal. So you again go back into the working phase after termination, right? Okay, next slide, please. Now we'll talk about the aspects of a therapeutic relationship. Can I have, yeah, next. Yes. Yes. Very important aspect, rapport formation. Now, like I said, trust is fundamental in the therapeutic relationship. If the therapist is not trustworthy, you're not going to be able to establish that relationship. In order to, let's say, establish the alliance, rapport formation is our first point where we create an environment where the client feels comfortable by expressing themselves, encourages honesty and deeper exploration to the self. Now, what essentially we talk about here is that um, as a therapist, you have to maintain confidentiality for your client. You have to show genuine care and empathy about the client's well being. So, our primary goal is the well being. How do we form rapport? Sometimes it's important to also pick up the nuances or the smaller bits to form a rapport. Let's say, your client brings up something like music. In order to form that rapport, you use music as a tool in terms of, what sort of music do you like, find a similarity, make the client feel comfortable that it's okay for them to share whatever they're sharing here. They don't have to feel upset about it. How do we show that they can share here? Is by asking them the right questions, maintaining a very empathetic approach, genuinely showing concern for them as well. Now, every therapeutic intervention needs to be tailor made. The same intervention may not apply to another person, even though they might have similar problems. Now, it is the individual's needs and preferences and the therapist's ability to tailor make this intervention that is important, which helps in enhancing the therapeutic alliance as well as responsiveness. Now, I'll give you a simple example. Sometimes people would prefer that we only do talk, we only talk in the sessions. Sometimes clients prefer that, once we've talked, they get a worksheet in the end, or they want like a work, what we call something that they can go back to, or they want handouts. It would really depend largely on your client, right? Rapport formation also becomes important because it helps you build that trust in that relationship to be able to tell them those patterns that nobody else is telling them. So if I don't have a good rapport with my client, they're not going to talk to me. I'm also not going to be able to tell them things that they need to hear from me. Okay. Next we have confidentiality. Can we go to the next slide? Um, as a mental health professional, confidentiality is essential not just for therapists but for everybody. When we talk about confidentiality in counseling, this refers to what you say to your therapist stays with your therapist. The therapist has to protect and respect the client's privacy. At all times, whatever your client has said has to remain private. You cannot disclose information about your client to other people, or about, let's say, um, about other people to your client, or anything like that. Ensuring confidentiality and privacy is utmost for building trust, and it's also important to maintain the ethical standards. If we are not keeping our data of the client confidential, it is actually punishable one. Also, um, we also have to explain to the client beforehand only that there are certain areas or certain situations where we may have to break their confidentiality, which would mean harm to self, harm to others, or when they're not being able to take care of themselves, or they're taking any unsound judgment. It's very important that we tell them that your confidentiality would be broken in these particular instances. Otherwise, whatever they say stays here. As a therapist, even if, let's say, for example, you needed help with a particular case, you would need to talk about it in supervision, or you need to talk about it in, let's say, with other therapists or with a psychiatrist, like I would talk to Dr. Mantosh. I would still maintain the confidentiality of my patient and not disclose personal data, not disclose any personal information about the client, and only focus on, let's say, what is essential for me to understand, or a goal that we have. Next is boundary setting. Yeah, we can go to boundary setting. I think we hear the word boundary a lot, but when we talk about boundary in a therapeutic alliance, it's very different, and it's very important for us to understand, because, like I said, a therapeutic relationship is not it's not an informal relationship. It is a formalized relationship. The alliance works on certain limitations and boundaries. There is clear guidelines and limits within a therapeutic relationship. There is what we call a professional framework that supports the therapeutic relationship, which also is important because it ensures the client's safety, it ensures their comfort. Now, when we talk about boundary setting in a therapeutic relationship, it's referring to the expectations of the therapist's appropriate behavior that is set by a what we call professional body, their training and their professional literature. Now, just to make this simpler, I will give you examples of the different types of boundaries that we have. Again, I would like to stress that boundary setting is important in a therapeutic alliance, because it then sets the professional and what we call formalized relationship of a therapeutic relationship. Now, let's say, for example, um, someone comes into the room, and in your therapy room, and they give you a hug. This would be boundary breaching, because there are certain boundaries that we have, which include emotional, physical, time, financial, and confidential. I'll go over each of them. Physical boundaries are basically guidelines about touch and personal space, or physical touch. Therapists typically and mostly maintain a non physical relationship with clients. There are only a few exceptions, and that would be defined by the therapeutic modality that we are using. Now, let's say, for example, if we're doing um, certain art-based therapy which would require movement of hands, or let's say manipulation of some things, then the therapist may use physical touch with the client, but in a very appropriate way. So there is no physical contact between a client and a therapist at any point, and there is physical boundaries between us, between the client and the therapist, right? Sometimes your client may have had a really good news or anything like that, and they would want to, like, shake your hand. It's okay to do it if you think in that particular situation it's appropriate. As a therapist, like I said, reflectivity becomes important, because certain things you might have to do because it's culturally appropriate. Like, let's say, for example, shaking hands is well within your boundaries, but hugging cannot be well within our boundaries. So it's very important for us to understand these physical boundaries. Emotional boundaries. Therapists maintain emotional boundaries by managing their own feelings and reactions appropriately. It's important for a therapist to have emotional boundaries in order to understand that they are the facilitator of the therapeutic alliance. And when we have emotional boundaries, it's because we want to be empathetically involved and not personally involved. Because sometimes what happens is, when we get involved personally, we might have biases, we might have problems within the what we call objectivity of the therapeutic alliance. We will not be able to see it objectively, which is why we always say that a therapist cannot be your friend, because as soon as your friend is your therapist, they've lost objectivity. And this is what an emotional boundary is important for, to keep that objectivity within the alliance, to know that this goal or this particular task is important for my client and not have a personal investment in it. Next is time boundaries. I think a lot of therapists also need to understand that time can also show boundaries. You have to have clear parameters around session length, scheduling, availability, what your structure would look like, ensuring that the therapy remains very focused and efficient. Now, let's say, for example, our client is talking and you have a 1 hour session and they are running overtime. And it happens a lot of times, people get in the flow. As a therapist, I need to know my boundaries, that I cannot go overtime every session. I need to tell my client also that our sessions are 1 hour, I think we should wrap up. Very gently nudge the client that our session is running over time. You can also say that if you would like to extend, I could extend. Sometimes client will say, no, I want to see you every day, I want to talk to you at this time. No, we have to keep our time boundaries very clear, because this helps us in making the relationship more formalized. It also leads to less dependencies, and it also shows commitment, but in a more formalized way, right? There are certain situations where your client may run overtime, which is okay. There are certain situations where a client may need an emergency session, which you can give. All of those things are important, but it cannot become a repeat habit. So, and like I said, in the orientation phase, we talk about all of this boundary setting. We talk about what is the length of the session, what will be the availability, what will be the frequency, what will be, what do you call, what will happen in cases of emergency. You orient them. And why we say it's important, because it helps them also understand that this is a formalized relationship. Financial boundaries usually are guidelines around the fees, the payment methods, any financial arrangements. It's very important that between client and therapist there is transparency and clarity that around finances, because this helps the alliance also become stronger, because you would want transparency in something like this. Confidentiality we already talked about. I'll just say it again, that ensuring confidentiality and privacy regarding the client's information is crucial for building the trust and maintaining the ethical standards. You also, like I said, we do explain the limits of it also. Boundary setting can also come, let's say, when where a client might bring up something which may seem like a boundary breach. I will talk about that in the ruptures to an alliance. Can I have the next slide, please? Yeah. Expectation management. Everybody comes into sessions with some expectations. Expectation management in a therapeutic alliance refers to clarifying and aligning the expectations of both the therapist and the client. Sometimes your client, or sometimes clients come saying, just fix all of my problems. But we can't do that. That's not what we're here to do. We have to explain, or you have to manage the expectations of the client. You have to make them more realistic. You have to make them more, let's say, goal focused, or make them understand that um, there are certain approaches and techniques, and there are certain responsibilities of the um, therapist as well as the client, in order to set realistic goals and timelines. So when I say realistic goals, um, as a therapist, my job would be, when a client comes in the orientation phase, clearing any undue expectations or unrealistic expectations that the client may have, and being honest about what we can offer, what we can do. When we talked about having that mutual trust or that shared goal setting, one of the aspects is expectation management, that we manage the client's expectations. Throughout therapy, open communication about progress. Whether are we going forward, are we going backward, have we made any progress, have we made any headway, what are the boundaries? Addressing the unrealistic expectations also is a part of the orientation process. How we also need to understand is that this is collaboration. So even the client will have some expectations from us, even we will have expectations from the client. So let's say, for example, if you're giving tasks, and your client is not doing the tasks, then you also need to help and reassess the expectation we have from the client as well. We will also have to do that as well, because like I said, it's a shared relationship, it's a shared goal, right? Next, can we have, yeah. Now we come to skills. There are certain skills that are used. The first is active listening. Now, active listening is a structured way of listening and responding to others. It focuses on attention of the speaker. So right now, I'm talking and you're listening to me, right? It requires more than, when we are doing this in therapy, this requires more than just listening to what the client is saying. Why active listening is one of the key skills that a therapist may have is because it requires us to look into the body language of the patient or the client. It requires us to look at the tone, the speech, the pitch. Remember, Dr. Mantosh was talking about speech. When you were doing the MSc, there was a lot of things that he said which were about speech, which was about language, which was about communication. Oftentimes clients reveal more in terms of their emotions and experience by just what they're saying and by also not what they're saying. So for example, if a client is talking to you but they're looking somewhere else, it gives us an information about whether they're making eye contact or not, whether are they comfortable talking to us or not. When we try and actively listen, we're not just listening from our ears, we're listening from our eyes, we're listening from what they're saying. It's very important for us. Passive listening is a one-way communication, or what we say, there is active listening and passive listening. Passive listening, when we say, is that as a therapist or the person, I do not provide any feedback. I don't ask questions. I just hear or listen to what the person is saying. I'm passive in my approach. I'm not making any communication. When I'm actively listening, I might ask a question. I might say something that will help my client probably think in a particular direction. And as a therapist, we talked about reflexivity, right? Or competence. One of the things that we need to do is we need to keep switching between an active listening and passive listening. When do I need to ask the question? When do I need to keep quiet? When do I use my silence as a tool, right? So active listening skills become very important because you're noticing the nuances or the smaller details that the client is talking about. And this helps in a therapeutic relationship because you notice the smaller things that others may not notice and that a client may not be aware. An example of this would be when your client is talking about something difficult that's been happening at work. They're talking about it like it's okay, but their leg is moving or their hands are fidgety. I'm noticing that as well. When they're talking about something they really like, they suddenly become more higher. When they don't like, they slouch. Looking at all of the nuances is also a part of the therapist's role within the alliance. Next, can I have the next slide? Oftentimes clients may say something that we may not know what they're saying, and it's okay for the therapist to ask for clarification, to ask for more details, like ask for more details in terms of directly asking for a question, rephrasing what the client is saying. So clarification is a skill that we use. Now, I'll give you a simple example here. If a client says, I'm feeling off, now, as a therapist, actively listening would mean I may ask my client, when you say off, what do you mean by that? Because I'm clarifying what they're saying rather than making assumptions. Because it's important for me to know exactly what they're thinking and what they mean to say when they're saying a particular word like off. This helps me reduce my ambiguities and any confusions that I may have about what the client may be thinking. So it becomes all the more essential for us to focus on that. Focus on what the client is saying by clearing our own doubts. Next we go to specifications. Specifications often happens is that sometimes our clients, it's a skill that we use. When our clients are talking, they may talk about too many things at once, or rather they talk about very broad things. As a therapist, as someone who is working with working with clients who may not find a structure in their thought, It's our job to narrow down very broad topics and pick out those specific details. This helps me also notice the patterns for the client to be able to understand later. Now, another example here is if my client says, I feel stressed all the time, the therapist would say, can you specify what situations make you feel more stressed? Why we do this is because clients within the therapeutic relationship or a therapeutic alliance, more specific details helps me make patterns better, helps me make those what we call hypothesis for a particular behavior better. So the more specific details I have, the better it is for me to overall understand what's going on. Next, reflection. Um, reflection, or what we call reflective listening, encourages the speaker to or the client to talk about more things in greater depths than they would like, and simply responding to, let's say, a directive question or not. As in the therapeutic alliance, reflection is very important, because when we're asking clients to reflect on what they probably feel or what they think or what came up, it helps them go into their own analysis of their own behavior, which is better, because this helps us increase what the other person is saying. It helps me clarify different thoughts, and it also helps me assure that someone's listening to me also. Like when I say a reflective question back to the client, they feel like something is being told to them. Why we also say that it's important for reflection to be a skill that a therapist should have or should be in the therapeutic relationship, it is because it helps clients look at different perspectives that we would want them to. We also make them see things from where we are seeing them. So reflection plays a key role. Um, it helps in what we also say that sometimes what happens is that when you give a reflection or when you give a reflective question, it increases the other person's understanding. It also makes them see different points of view and helps in perspective, shifting the perspective that usually they wouldn't be able to do. So that's why we use reflection as a skill within the therapy process. Okay, can I go to the next slide? Paraphrasing. We've all heard this quite a few times. Paraphrasing means rephrasing whatever the client is saying and putting their thoughts in my own. So sometimes clients talk about lot of things. They talk about work, they talk about family, they talk about so many things at once, and I'm listening to all of this. As a um, as a therapist, um, I don't merely restate what the client is saying, but you're also trying to shorten what they're saying, make it more comprehensible for a better understanding for them and for you. So when I'm paraphrasing, I'm essentially taking whatever data or whatever information's come to me, putting it in a smaller, crisper way, and saying it back to my client so that if in case I feel like I've missed something or they feel like I've missed something, something can be done about it. Now, let's take an example. The client says, I have not had enough time to study because of my work schedule, my grades are suffering. As a therapist, I will paraphrase this in such a way that I would say, it's been hard for you to keep up with work and school, and now I feel like you're concerned about your grades. So essentially saying the same thing, but in your own words, expressing what they may be feeling. So that's paraphrasing. Next, summarizing. Summarizing is basically slightly different from paraphrasing. Summarizing is recapping all of the points that the client has discussed to ensure the understanding and highlight important aspects of that conversation. So when I summarize, I would go point by point and also ask, should something be added here? Have I missed something? Okay, next. Confrontation. When we talk about confrontation, a lot of us refrain from confrontation within the therapeutic alliance, thinking that it might rupture the alliance or it might break the alliance. However, if used responsibly, it can be a very important tool within the therapeutic alliance, because it helps the client also see from your perspective. It means to have a responsible unmasking of the discrepancies, distortions, um, things that the client is trying to hide, which become a hindrance in behavioral change. So it requires both the client to be able to deal with feelings of reality, which is revealed through this way. So sometimes we confront clients with something that we feel like, they're not being able to see. And we only can do this if our rapport is very strong with the client. If we start confronting a client whose rapport we don't have with it, they might feel hurt, they might feel upset. So, let's say, for example, when a client is saying something and you want a little more um, mm, detail on it, you can simply say, I'm a bit confused when you say that you don't want to go to work. Whereas on the other hand, you also say that work is very important for you. Can you help me understand what is this contradiction? So I'm being very forthcoming and directive that I am also seeing a contradiction and you need to help me with it. So I'm confronting it because we need to unmask those discrepancies within therapy and also break those patterns of distortions. But we cannot do it without telling our clients back. So somewhere we have to also confront them with what they have put on us. But it's done in a very gentle way. It's done in a very non-direct way, not with let's say a condition. So when we were talking about the components of therapeutic relationship, if those are fulfilled, we're able to do this better. Next, probing. One of the skills that we use in a therapeutic relationship, or rather to establish the relationship, is probing, asking follow-up questions. When we say, what does that mean to you? Or rather, what do you think are the triggers of your sadness? Or do you think that maybe does this particular situation act as a trigger for you because it reminds you of something from the past? So you probe more. The more you probe, the more data, or let's say information we get. The more information we get, the better we will be able to help the client find their own, what we call, patterns, and break those patterns as well. Next, silence. It's funny because sometimes we think silence is uncomfortable, but silence is important too within a therapeutic relationship because it gives time for the client to think. It gives time for the therapist also to think about what the next question could be. It's also particularly important when the client is engaging in self-analysis, which is a helpful way to achieve the ultimate success of a therapeutic or a counseling process. Because sometimes when there is silence in a therapeutic alliance or a therapeutic relationship, it's because the client may be analyzing what the therapist has said. And they may not tell you immediately, they'll tell you later if they have to, or they may not tell you at all. But silence does not have to be uncomfortable in a therapeutic alliance. If there is trust, if there's positive regard, if there is a mutual respect, silence acts as a very important tool, because it not just um, strengthens the self analytical aspect within therapy, but it also strengthens the relationship. That when we're silent, we're not feeling the need to fill the silence with some question or anything like that, because we can sit in each other's space without feeling discomfort. Next, interpretation. I think there are a lot of skills. I'm not sure if everybody is, let's just say, are there any questions that, or I think I'll take the questions in the end. Okay. Next, we talk about interpretations. As a therapist in a therapeutic relationship or in the working alliance, making interpretations is essential because the client may not be able to understand it. It's important that we look at the hidden meanings behind their statements and actions. Most of the time, we have to make these interpretations. We also make over interpretations sometimes, but it's important that we understand those interpretations and their diverse forms and the content. Because when we look at interpretations, or rather when we're interpreting a particular behavior or a thought, we should not overinterpret one. The other is we should also know which intervention or which approach are we using, so that we can present that discrepancy to the client, or we can present it to the client in such a way that they also see where we are seeing that particular behavior from. So like, I'll give you an example. The client says, I'm so sorry that I'm yelling at you, don't take it personally, I can't help but I find you very difficult to look at. Whenever I think of you, I feel like yelling. Yes, clients may say something like that. As a therapist, I have to interpret this behavior. I have to interpret what they're saying and be able to show them what they may be feeling. Now, as a therapist, I could say, perhaps it's really feelings of anger that you are experiencing, which is coming up here when you feel like yelling at me. I don't take that personally. I'm interpreting their behavior for them in context to their life. Putting their life in perspective and context becomes important in interpretation because I'm interpreting what they're experiencing here also outside. Okay. And that's a skill which comes with time. I'm not going to say that it happens immediately or there's any book that you can learn from it. It comes on its own. It takes some time. Next, we have self-disclosure. Self-disclosure is also a skill within a therapeutic alliance. Now, when we talked about what the therapeutic alliance is, we also focused that the alliance is focused on the client, not on the therapist. But certain times, or what we call certain situations, there is self-disclosure of the client, of the therapist. Sorry, self-disclosure essentially means to provide some amount of information about the therapist in the therapeutic alliance so that it will help the client understand better. Now, it's critical for building the function or building the relationship because it shows some authenticity, some genuineness, some integrity, and it's also essential for the client to feel like you are also another human being or another person, and there isn't that power dynamic that we look at. Now, when we look at self disclosure goes beyond what we call standard professional disclosure of, hi, my name is Kamna Serene, I'm a therapist, I'm clinical psychologist, I work at FMRI, or sorry, Fortis Hospital, my fees is this are the policies. It it become this is what I call professional, my professional credentials. It goes a little beyond that. The reason why I would do it is, can I have the next slide, please? Okay. um when we talk about self disclosure here, the key factors to keep in mind is the purpose of that disclosure. If I'm giving out any information beyond my professional credentials and so on and so forth, what is the purpose of it? Why am I giving that personal information about the therapist in that relationship? If not done properly, it is considered a violation. We're not supposed to disclose about ourselves. What amount of information is being disclosed? Now, for example, sometimes we can say that, let's say a young client comes in. Hello.
Teach. I'm listening.
When we talk about self-disclosure, the duration of self-disclosure is also important. We cannot take space from the client within that relationship. It should be short. It should have a purpose within that. Now, say, for example, if I am disclosing that I studied in Delhi University, it's because it's helping me establish that connect with that client, but I'm not going to talk about it too much. The timing.
Also, I think one of the things one needs to understand, and this is a question a lot of young people ask me, please also understand that what is in the public domain, you can't not say that I'm not going to disclose it because it almost feels unnatural, right? So, for example, if somebody asks me that where did you do your MD from, then I will say Civil Hospital Ahmedabad. It's public domain. Now, there is a difference between when somebody asks A, what is in public domain, and B, the nature of the question asked, right? So, you will need to distinguish between that. So, you may be sometimes even asked, let's say something like, the kind of, if somebody asks you about your salary, you need not answer that. uh, and I don't think you need to do that. You can very well say that in any case, if you'll be working in most places, you would expect, this is the other part of confidentiality, right? So let's say Kamna Sarin's salary and Mankosh's salary, they don't know. And that is the relationship and between the employer and the employee as well. So that you can easily say, okay, sorry, I'm not supposed to disclose it, and which is absolutely fine. But you don't need to dodge a question like you just mentioned. You don't need to do that. Remember, A, it is in public domain or not. B, the nature of the question. Sometimes a question may have a therapeutic relevance and you can answer accordingly. In your mind, you should always think therapeutic relevance of what you are saying. Whatever you say must have a therapeutic implication. It's not a coffee table conversation. You're not meeting a friend for a cup of tea. So have that perspective. And I am now going to leave you in the good hands of the bright Dr. Mantosh Kumar and Kamna Sareen, who's been kind enough to take a session from her leave and that kind of work-life balance that happens in life, where you decide to take a leave and then you have to find a place where you have both internet and place from where you can take a session. But tomorrow I'm coming and bringing to you a very interesting conversation. Feel free to come with all your questions on AI because we'll have an absolutely brilliant expert. Saurav Banerjee, who's going to come on and talk to us about AI and teach all of us, including me. And
Thank you, sir.
thank you.
Sir, just a question here about questioning skills. I think you also brought it up earlier when all of the questions you ask in case history, are they open-ended or close-ended?
I would always ask open-ended questions, and I would get a lot of information in open-ended questions. Very, very rarely, when you go deeper into the conversation and you want to be very specific, then you ask certain questions which are very closed-ended to understand the picture more clearly, right?
Absolutely. So one of the skills that we have in forming a therapeutic alliance is questioning skills. um, Open-ended questions help us to gather more information. They help us to understand. We get longer answers. There are no right or wrongs, and there are more explanations given to us. So we encourage more open-ended questions so that they can elaborate and help us give specific examples. Next, we also sometimes use close-ended questions. Close-ended questions can also be direct. Why we essentially have close-ended questions is because it gives us relevant information that may be important. Now, let's say, for example, um, I ask an open-ended question like, what is your routine like? It's an open-ended question. But if I need to make the same question in a more close-ended way, I would probably say, what time do you sleep? Right? So it becomes close-ended. It gives me the same thing. Now, switching between when I need to have an open-ended question, when I need to have a close-ended question is important in a therapeutic relationship. Like I said, how we do active and passive listening. Similarly, you keep switching between the questions that you do. Yeah, I think that's the next. Yes. Now we talk about ruptures in a therapeutic alliance. Ruptures in a therapeutic alliance refers to the disruptions or the strains in the relationship between the therapist and the client that hinder the effect of collaboration and progress within therapy. Anything can be a rupture, right? These ruptures can occur because of several reasons. The first will be misunderstanding and miscommunication. Also, it's very important for us to understand that ruptures within the therapeutic alliance or relationships is very normal. It's okay. We have to work through those ruptures. It does not mean that the relationship is broken. In fact, working through ruptures is a very important aspect within the therapeutic alliance because it builds the strength of the alliance. It builds the trust that despite having a misunderstanding and miscommunication, I'm still relying on my therapist. My client is still relying on what I'm saying. Now, when we talk about a rupture such as misunderstanding and miscommunication, sometimes what happens is that there is a difference in the expectations as well as the therapy goals or the methods, and our communication can be unclear, which can lead to a rupture. A resolution of this or how we resolve this is by clarifying the rationale behind why I'm using a particular approach, emphasizing the long term benefits of the underlying issues. I have to encourage open dialogue to align my client's expectations within the therapeutic goal. So, if there is a misunderstanding, you work through that misunderstanding. If there's a miscommunication, you work through the miscommunication without making it feel like this cannot be worked through. And how we do this is open dialogue, right? Next. Transference and counter-transference. It's very important for us to understand that transference and counter-transference will happen within a therapeutic alliance, because we are sharing a non-judgmental, empathetic, positive relationship. It often happens that that the client may have transference towards us. Now, when we talk about counter-transference, sometimes there may arise unconscious feelings or reactions from either the client, which is transference, or the therapist, which is counter-transference. And this can interfere within the therapeutic relationship if not addressed. It needs to be addressed. Also, it can be positive and negative. Sometimes the client may have positive transference towards you. They also might have negative transference towards you. Even the therapist may have it. Now, this happens as the client may start to identify the therapist as a prominent figure, and some unresolved issues may arise, and that becomes a problem within the relationship. This can also happen from the therapist's end. When we are in the therapeutic alliance, we use transference as a tool to help help the client reach their goals. We also try to understand why there may be counter transference. Why am I, as a therapist, feeling this way towards my client? What behavior are they showing? When we work through this and resolve this, again by open communication, also identifying what role or what figure is coming up for the therapist as well as the client, we can work through our counter transference. Transference can make one feel uncomfortable. It can also feel like a boundary is breaching. But we have to address it within the relationship that, hey, I see that this is coming up for you. And, I see that you're feeling anger towards me. Seems to me that this anger that you're feeling maybe because it's reminding you of the anger you may have towards your best friend. Similar, right? So I used anger as a tool, the transference that the negative transference they're having towards me as a tool in the relationship, in the alliance. Next, unmet needs and expectations. Yeah. When we talk about the unmet needs or expectations, clients may feel disappointed or frustrated if their needs and expectations regarding the therapy outcome or progress, and they feel like they're not being met. This may happen because the client's expectation of the therapeutic process may be different and may feel demotivated, that I thought something would be different. However, when you collaboratively set realistic short-term goals, discuss the process of therapy, emphasize that whatever improvement we're having will be gradual, we are able to work through these unmet needs or expectations. A lot of times, we would have situations where there would be urgency within the therapeutic alliance that I have come to you, we've done 5 sessions, I'm still not feeling better, right? And that is that's an unmet need or an expectation a client may have. We have to address the frustration. We have to address this urgency and also tell them that, there is a process in therapy. I know it can feel very difficult. It can feel very frustrating. Addressing this becomes important. And also, sometimes we should reassess our goals. Are our goals of the therapeutic alliance too large, whereas my client would need more something short term? So, this is another rupture that comes up. Next, boundary violations. We talked about boundary violations. Violations or ambiguities within the therapeutic boundaries, such as breaches of confidentiality, inappropriate dual relationships, these can impact the trust and the therapeutic alliance. If I'm playing a dual role within the alliance, it's incorrect for me to do this. This happens when there is breach or deviations which are against the ethical professional guidelines that govern the therapeutic relationship. Now, if my if I am undermining, if the violation is undermining the trust, it's compromising the safety, and it's harming the therapeutic process, then it's a boundary violation and it's a rupture within the relationship. In certain situations, we also have to break or terminate the relationship prematurely because of a boundary violation. A simple example of this could be when the client may say that they want to, see you for coffee outside, and you have to say no, that this is a boundary violation and it's not okay. Or they keep asking for your home address or something like this. You have to assert that these are ruptures and boundary violations, and if they have happened, the relationship or the therapeutic alliance is not therapeutic and has moved from the therapeutic nature into something else. And we need to make sure that that doesn't happen. Next. Yes, clients should be educated about their rights, their ethical standards, and so should therapists. The therapist needs to adhere to the ethical code of conduct. America, the APA gives the code of conduct. There are other organizations also give conduct. Depending on the degree and the violation, the resolution would be different. Now, let's say, for example, if the boundary violation is smaller, it would not lead to termination. If it's very large, it would lead to termination and also can involve the organization and so on and so forth. So I think we also need to understand that depending on that. Next, we come to cultural and personal differences. Sometimes cultural and personal differences can also cause ruptures within the therapeutic relationship. Differences in cultural background, values, personal beliefs between the therapist and the client may lead to a misunderstanding that can cause tension between the relationship. Now, this may happen when the therapist may be unfamiliar with certain cultural nuances or certain beliefs and values that are important to the client. We also need to understand that when this happens, it can feel for the client that my therapist is not thinking in the way I want them to think, or they're not understanding my cultural differences. It's okay for the therapist to ask that, could you help me understand a little bit about your culture, because it's may be different from mine. And if they feel like the violation, or let's say the difference is too much, they will also bring it up and you can communicate about this difference. Next, addressing the ruptures. Now, we talked about this. I think I said it through the what do you call through the different types of ruptures. But like I said, working through the ruptures of a therapeutic alliance is very important. Openly communicating, discussing the conflicts that are coming up can help identify and resolve the misunderstanding and cause and reduce the rupture as well. One important aspect of working through the rupture is validating and empathizing with the client and with the fact that a rupture is being felt. Validating the fact that I feel like something is wrong, I feel like you've misunderstood me, or I feel like you've miscommunicated is very important within the therapeutic alliance, because the alliance or this working relationship runs on the feeling of mutual trust. So, both for the client and the therapist. Acknowledging their feelings, their experiences, demonstrating empathy repairs the trust very well and rebuilds the trust. Now, I'll give you a simple example. Sometimes, often, um, clients would, text and call and so on and so forth. And as a therapist, you will now then assert your time boundaries, right? And the client might say, I did not like what you did. How could you not, pick up my call, so on and so forth. You would validate and empathize that I know that this is difficult for you. However, we need to understand that we cannot speak outside the session time because it's a boundary that we set. So, again, you are working through that. We are working, communicating through that. We're building that trust. Okay. Revisiting goals and expectations, clarifying the therapy goals, the what looks like their expectations, what is important for them, realigning our expectations for both the therapist and the client. It helps in what we call increasing the collaboration. And like I said, this is a collaborative approach. The alliance works on joint collaboration. So when we are revisiting our expectations and goals, the collaboration increases and it moves towards what we call the expectations that we have from the relationship in itself. Then next slide. It's also reflecting on the therapeutic relationship. Therapists encourage reflection on the therapeutic relationship itself. Exploring the dynamic between the therapist and the client can also help contribute to the ruptures. Like I said, there are some personality variables also that affect a therapeutic relationship, right? Some may come up within the relationship and would need to be addressed. That is important. Now, when we're talking about repair and rebuilding the trust, if we put consistent effort to repair the rupture by understanding, by respect, by responses, we can rebuild the trust. We can rebuild that relationship, right? And once we're able to rebuild that relationship, it becomes all the more important for us to understand that the process that we talked about within the rupture is to mold the rupture back together in the alliance and make the client feel like their feelings are valid. Next, now therapeutic alliance can vary across different therapeutic approaches. This is due to their distinct theoretical foundation, their goals, their techniques, and the client therapist interactions. I'm giving you we'll just talk about a brief overview, not much. And it's important that I'll just focus on the alliance mostly. Now, when we talk about psychodynamic psychotherapy, it mainly focuses on what we call the unconscious processes, the unresolved conflict. Now, the alliance in a psychodynamic approach emphasizes that the therapist is an empathetic and an insightful figure who will help interpret the client who will help interpret the client's unconscious motivations and past experiences. Essentially, what we do here, what largely happens here, is that the the role of the therapist is that they maintain a neutral stance. They encourage free association and interpret transferences and counter transferences and move towards insight. Can we have the next slide, please? Um, Now, this is the role of a psychodynamic therapist. How they do this is they build trust through an empathetic understanding of the client's deep seated emotions, helping the client explore their unconscious conflicts, right? So the role here is to become a facilitator of the unconscious conflicts. Next we have, can we go to the next slide? We have cognitive behavior therapy. The focus of cognitive behavior therapy is more on maladaptive thoughts, emotions, behavior through a more structured intervention. So there is a high collaboration between the therapist and the client to identify and challenge cognitive distortions, develop coping strategies. Now, here the role of the therapist is that they actively engage in problem solving, they teach skills, they provide feedback, they provide what we call principles, they probably do tasks and skills, as opposed to in psychodynamic, which is a lot lesser collaborative in nature. Now, here the alliance would look more strong on setting goals, conducting experiments, providing restructuring techniques, and also showing the negative thought patterns. So there, it's the prominent figure is the therapist who would help uncover the unconscious needs, whereas here it's more collaboration on the behaviors and the tasks. Next, we have humanistic. Humanistic psychotherapy focuses on self actualization, personal growth, positive regard, empathy, genuineness. In a client centered approach, or what we call a humanistic approach, the environment or the alliance is on a lot related on trust, non judgmental environment, explore their feelings and experiences. Now, here, the role of the therapist is to listen actively, reflect the client's feelings, promote self-awareness and autonomy more by listening. Now, the connection or the genuine connection within the alliance is what is essential here. It helps empowering the client make their own choices and the values that they have. Last, we have the family systems approach. In this, it focuses more on the relational dynamic patterns within the family systems to promote healthier interactions. The collaboration between the therapist and family members to identify the roles, the boundaries, the communication patterns, and the relationship issues that may be felt. Now, the role of the therapist here is to explore, reframe the patterns of communication, develop what we call how family members are interacting with each other. The role of the therapist helps to increase the adaptive functioning within the family. Now, here, what they essentially do is that when we are building this alliance, each family member is validated for their different perspective, and a mutual understanding is built within the client. And we address the relational challenges within the family approach. So it's also very collaborative as well, and there's a lot of different people's perspectives that's taken. Last part, mistakes in therapeutic alliance. I think we've covered a large part of therapeutic alliance today, but I'll quickly go over this and I won't go into the details of all of it, but if you have any questions, we can take it up. Some of the common mistakes in a therapeutic alliance is that sometimes we may lack empathy. If we lack empathy in that therapeutic alliance, it becomes very difficult to hold that alliance together. If, as a therapist, I'm not feeling empathetic towards the client, it is important that I address that, reflect it. Because if my client feels that I'm not being empathetic, there is no purpose of that alliance. Second, overstepping boundaries. We have to be conscious, extremely conscious about the fact that we're not overstepping boundaries, nor is our client overstepping our boundaries. So that is very important. And this is an often common mistake we end up making, is that we don't realize that we're overstepping the boundaries. Um, like I said, picking up a phone call, or rather, texting outside of the session time is also a boundary violation, which often we end up doing, and we should not, right? Imposing personal beliefs. We also need, like, one of the mistake in a therapeutic alliance is that we allow our personal beliefs to guide the relationship, which is not correct. We are facilitators as therapists. We are not ourselves in terms of our personal belief systems, our ideologies. It's not, we cannot let the alliance be dealt with by imposing our personal beliefs. Ignoring cultural differences. Culture plays a huge part in who we are. We cannot ignore the cultural differences that come up for us. Addressing those cultural differences, acknowledging them, also understanding what cultural differences is coming up within the alliance is also important. Lack of communication. Often we do not communicate what is going wrong. This may happen where therapists also are not communicating. If I'm not communicating to my client what is going wrong, it becomes a mistake in the alliance. It also breaks my alliance very badly. Inconsistent availability. When I had talked about this in the beginning, you have to show a commitment towards your client, that you are invested in their better well-being. If as a therapist I feel I'm sorry, if as a therapist I'm not being available, my alliance or my therapeutic alliance will not be strong, because it will not show commitment towards that. So it becomes very important for me to be available and not have inconsistencies in my approach, because this then becomes the reason why an alliance has not built in the first place. Failures to address ruptures. Like I said, ruptures are very normal. It's important for us to acknowledge those ruptures and work through those ruptures. If I'm not being able to work through those ruptures, then it will break my alliance again. Power imbalance. I've said this before. A therapeutic relationship is not a power relationship. It's important for us to understand I do not have the power, nor does the client have the power. There is no imbalance of power happening. Last, inflexible approach. It's okay to not know a particular approach, to also refer out if you don't particularly think that a intervention is, you're able to keep that intervention for the client. If I do not show flexibility in my approach, I can then cause more damage. And I have to understand that sometimes in a therapeutic alliance, because of the inflexibility in my approach, it can lead to problem in that alliance, right? I think we've come to the end of this, and these are some of the references we've used. I'd like to now, I think we should take some questions
So I
that
have,
sir also.
Kamna, I have starred some of the questions, so you can look in the
Oh, wow,
lecture.
great.
So few of them you have already answered, so I've not marked them. But maybe you can look into
Okay,
one of the.
I'll look into one. So one of the questions is, can a client gift their therapist? So usually we mostly say no, you should not accept gifts from therapists. But sometimes what happens is, now let's say if a client gets sweets, or they've cooked something, or they've made something and they want to share it with you, you would possibly take that. You also need to understand that if a gift, or if, let's say, a gesture is going to aid the alliance, you can take it. Now we often encourage that, if they've painted something, or if they've done something, if they've done something from themselves, where it's okay to take as a gift. Also, if you do get a gift, it's important for us to display it in the therapy room, show it to other people also, so that it's not personal. Can't our family members be our clients? So can our family members be our clients?
No, no, never,
No.
never.
No,
No.
never.
Not a family member, not a friend, not a neighbor. In all those areas, there will be some form of biases. You will never be able to be completely unbiased in certain situations. So, not a family member. No one that you know in your social circle.
Absolutely. Would it be appropriate for the clinician to partake in a cultural act that would provide the client ease before the start of a session, or is that a breach of physical boundary? Um, oh, let's say, for example, uh, if there is a physical touch, if there is a breach of physical boundary, no, we would not, that's not appropriate behavior. Let's say, for example, a client does, come into the room and shake your hand. Yes, you can shake their hands. That's the maximum you would go. And we also shouldn't or we wouldn't engage in any cultural act to show the client to before the session also, because I don't think that would be appropriate in terms
So
of
our
behavior.
own beliefs, our own
Yeah.
ideas, values, we keep it to ourselves. We don't display,
Yes.
we don't talk about it. If someone asks for our own values and judgments, we would not dodge the conversation, but we would like to focus and we would say that we are going to focus more on you and not so much as on ourselves. You know?
Absolutely. So there's a question, what if the harm to self part of the confidentiality agreement leads to the client being resistant with what they tell us? Would you like to take this up?
Yeah,
Because
yeah,
this would
well,
come up.
definitely. It comes up in not just in therapy, but even with the psychiatrist, it happens
Yes.
a lot more. If the self harm is under age below 18, then definitely a family member has to be involved. We take the consent from the patient, we tell them the need for informing the family member. If the patient or the client is above 18, still we kind of make a pact in a way that this is okay, we are not going to inform, but you have to kind of understand that there has to be an extent where we have to let some help, not just family, like we need to involve someone so that we can avoid this particular kind of behavior, and we can prevent certain harm to self, right?
Absolutely. There's a question here which says that what to do in cases the client shows negative transference and becomes a threat to the therapist. Like I said, we also have to understand the role of transference within the alliance. Even if negative transference is coming up from the client's end towards the therapist, if it is not a physical threat or if it's not a threat to the therapist, we will work through that. However, if it is a threat to a therapist in terms of physical threat or let's say emotional threat, a therapist can terminate the therapeutic alliance with the patient by explaining to them what is happening. Here, someone has also written, how do we work with counter transferences? How do you work without it making them feel uncomfortable? Like I said, when we work in a rupture, the rationale behind what we're experiencing, what we're feeling needs to come up so that we can make them understand from the perspective that we are taking. So there's a question, what is hypnopompic and hypnagogic
I
hallucination?
think I had said it in the when I was sharing
Okay.
the slides, but hypnopompic and hypnagogic both are physiological phenomena, can happen to any individual, does not necessarily that they have to have any kind of pathology. Hypnopompic when you are waking up, hypnagogic when you are about to sleep. Just when you're about to wake up and you have just opened your eyes, you might have certain hallucinations, can be auditory, can be visual. Hypnagogic, similarly, just when you're drifting off to sleep, you have closed your eyes and you just open your eyes a little bit in between when you are about to fall asleep, and you can have some hallucinations, either auditory and visual, and those are physiological hallucinations. Okay.
Hmm, absolutely. There's another question that says that what if your client wants to come back after termination? Absolutely. If the client wants to come back after termination, then we would take them up again, depending on if you have the space. If there was a violation and then there was a termination, if you've not been able to work through that terminate the violation, we would not take up the client again. On an average, how long does it take to terminate a therapeutic alliance? Like I said, there's no such structure or number of sessions. Termination is again a process. It is first brought up with the client of why you think there would be termination of the therapy sessions, because all the goals are met. You probably do another goal analysis if you need to, if there are other things. And then based on whether the client is comfortable, do you agree for termination?
So there's a question.
Yanas?
The question I think you should answer this: how to rectify the dependency.
I think one of the myth that comes is that psychotherapy creates dependency. Absolutely not. I had said this in the beginning also. The goal of a therapeutic alliance is to build autonomy and independence in the client. when you see that your client is becoming dependent to, let's say, the therapeutic process, we also have to be reflective in our approach. We have to change our approach. Probably use more tasks at that point in time and allow the individual to see that they can do things by themselves and you are taking a back seat, right? Another thing is if the frequency of sessions is too much, it can create a dependency. So phasing out, allowing the dependency to decrease more naturally, and also challenging the dependency. Like I said, confrontation is a skill that also we pick up in therapy. So there's a question here which says, can a psychiatrist provide psychotherapy? Or does this therapeutic alliance only exist between other mental health professionals other than psychiatrists? Nice question.
I wouldn't do therapy because I'm not qualified for it. I would always ask my patients to go to a therapist who are certified, who have the good education qualification to actually provide therapy. Therapy is not a conversation. Therapy is a very guided, uh, you know, uh, guided conversation between two people where the therapist helps, focused conversation rather, where you're focusing on your areas of problems or issues that you want to rectify. And how do you do that? You do that in a therapeutic environment, not with anyone, not with a friend, not with another doctor, not with a psychiatrist. If the psychiatrist has the qualification, which is the case in Western countries, and sometimes in India also, there are certain doctors, psychiatrists who have done certain certification courses in therapy, then yes, they can do therapy. But most of the psychiatrists, they can probably sit and talk and listen to you and counsel you at certain times. But when you talk about therapy, it's better to go to a therapist.
There's a question here that says, what if a client says abusive words during therapy out of anger? Like I had mentioned, sometimes clients do end up projecting a lot of what they're feeling on the therapist, and they might use abusive words. We can politely ask them to refrain from using abusive words. However, in certain situations, if they're going through, a severe mental health condition and they're having that and they might not be able to listen to you, you can also end the session if you're feeling uncomfortable, because like I said, safety is at its paramount. We need to keep sure that we are safe and our client is also safe. um
I think someone has written a question, very nice question, that would the boundary of the session be any different if the client is a child? What if they want to gift a
oh
painting or a card they made? Does one accept it? Definitely, definitely accept.
yeah,
I mean, that's
yes,
what you can display it. You can show to other people. You can, that will help in building the therapeutic alliance, I believe.
absolutely. And it's also important for us to show the, let's say if it's a card, if you put it outside, it's validating the feelings of the client that my work is being displayed. Ma'am, what if a therapist becomes emotional, cries during a
I have only
session? Is
clarity. In fact, I did not read the question properly. What you had asked was, can a psychiatrist provide psychotherapy? That I answered that question. But
Yeah,
therapeutic alliance is made between every patient and a doctor, whether it is not just necessarily a psychiatrist or a psychologist or any other doctor for that matter, even a general physician, a cardiologist. They all have to have that kind of an alliance. Obviously, in therapy, because the conversation plays a huge role. That is why we are talking about therapeutic alliance in psychotherapy. But otherwise, even with me, when a person is sitting next to me, I would have to have that, kind of, I would provide that atmosphere to the person to be able to sit and talk without them feeling, guilty, ashamed, or feeling that they cannot share certain information with me, right? Yeah.
yeah, I think Sir said that very well, that in even in between a doctor and a patient, a therapeutic alliance is important because even that relationship is therapeutic in nature, right? Someone's asked a question here saying, ma'am, what if a therapist becomes emotional, cries during a session? Is it a boundary violation? No, it's not a boundary violation. However, having, let's say, a meltdown, or not even a meltdown, or crying too much as a therapist in a session would then shift the nature of the shift the session onto the therapist. Hence, it's not we do not recommend that a therapist cry during a session. But if, let's say, for example, there is an emotional story, or there's something that the client is talking about and you're feeling slightly emotional, and if you have a few tears or a tear rolling down, it's okay because it shows genuineness, which is important in a therapeutic alliance. We can't be stoic in a relationship, right?
We'll take few more
Uh,
questions because it's already past 6.
yeah,
है
it's
ना?
already time. Yeah. So there's a question that says, can no, how do you differentiate between trauma-induced depersonalization and psychopathology? Yes,
Trauma-induced depersonalization and psychopathology.
psychopathology.
But one thing is very clear, you are talking about trauma induced. That means there is a history, there has been some trauma, and you talk about it, you understand, and that is where the depersonalization as a symptom is appearing, versus depersonalization as a part of any other disorder or a syndrome. Maybe it can be dissociation that is happening. It can happen also in severe depression. It can happen in some forms of anxiety disorders. So trauma induced, yes, definitely there's a trauma, there's a history of trauma, whether the person uh, had the trauma themselves, or it happened to someone that they were very close to, some family member or a friend, and that kind of brings in the kind of post-traumatic, post-traumatic stress, and depersonalization in that is also a symptom, right?
Hmm.
Yeah.
There's a question that says that how to say no to a client after a session, or how to say no to a client without hurting them. I think what I had mentioned is that if there is genuineness within our approach, and also there is assertiveness and not aggression within our communication skills, we will be able to tell the client what we have to say, or even say no without hurting them. And if they are feeling hurt, we also validate that hurt. That I understand that you're feeling hurt because I've said no. So just a clear communication helps in talking and not let's say, not addressing the feelings behind it. I think we're good for today. So, do you think so?
I think one question keeps coming up. Yeah, can a therapist use anecdotes from the personal life in the therapy session? Would that be a breach of ethics as a therapist?
Uh, Depends on the nature of anecdote, depends on also the purpose of it. If that anecdote could help in perspective shifting for the client, then yes, it could be used. And also, we can share anecdotes without giving personal information. So, when we don't give out personal information, then it's okay for us to share those anecdotes and just help the client use that as a reference point as well. But like I said, that disclosure would be important to see the purpose of it, if it's going to help them or not. So yeah, I think
I
we're
would
good
also like
moving
to add
forward.
that anecdotes sometimes can try to be very careful about any form of anecdote about your personal life or anybody else's. It's very important that the person should not feel that their problems are being minimized in any way. Anecdotes generally does that, like I know about a story, so you don't say those things again and again. Be very, very mindful that this, like you were saying, is going to help the patient realize something in the therapeutic environment, is going to help them. Also, that you have made that rapport with that individual, that they can take that anecdote. I mean, if the rapport is not formed, you cannot just say anything in front of them, right?
Yeah.
Okay, I
All
believe
right.
one question. I think you have already answered this, but I want you to again look at it. How can we as therapists effectively handle breakdowns?
Our own breakdowns?
Our own.
Oh, okay, okay. One would be very important to understand, where is this coming from? Why, what is
Mhm.
making me break down? Again, reflecting or using that sense of insight of what is it that I'm feeling that's coming up for me that's making me break down. Also, is there some unconscious need, or is there something that's coming up? Like we say, we tend to validate what others are experiencing. Sometimes you also have to validate why what we're feeling. So I think that is one way to manage a breakdown. Looking at all of our trigger points and our patterns of why this is coming up. I think that's also really important when we're looking at a breakdown, and also allowing a breakdown to happen. Because once you allow the breakdown to happen, it's also then resolved, right? So I think that is something we can
One
do.
question, because finally someone has asked some questions from MSc. Okay, so if a
Okay.
psychiatrist and therapist are working together with a client, both of them would keep updating the MSc. Yes, definitely. MSc is
Yeah.
what we do every time that you meet a patient or a client. You are going to have an MSc, which is of that cross-sectional MSc, and that MSc would help us understand how much the patient has either improved or not improved, or something new has happened. You can always share notes with your colleague who is also working with this individual, so that you better understand what they are going through. I
I think
think
one
we
thing that we are
both.
jumping, I think we forgot to also say that a therapeutic alliance also has to be between two practitioners for that client.
Yes,
Like, a psychiatrist and a psychologist also have to have a good therapeutic alliance because for the client, that alliance is important,
yes, yes.
right?
On that note, I think we will be concluding our session today. Do
Yes.
you remember to finish the assignment? I think Roshni will be updating the assignment. Yes.
Yes, yes. Thank you so much, Dr. Mantosh and Kamna. That was a very, very insightful, interactive, and I think a huge, huge learning, and given us all a lot of food for thought also. So thank you so much. And yes, everyone, the link for the assignment is there in the description box for today's session, as well as it's pinned in the comments. So again, the deadline is 15th of July, so you can take your time, brainstorm, apply your mind, and then choose the correct option to answer those questions. Thank you so much. Tomorrow, as Dr. Parik said, will be an interactive session on artificial intelligence and mental health. So, if you can see how the sessions are going, some sessions are more theoretical. Tomorrow will be more of an interactive session. I think there won't even be a presentation. So, bring on all your questions for artificial intelligence, and hope you all enjoyed the discussion tomorrow also. Thank you so much, and thank you once
Thank
again
you.
to our
Bye bye.
experts.
Bye
Bye
bye.
bye.